Folks in Rochester, are you still seeing the PowerPoint?
No.
No, okay. We somehow lost the sending of the PowerPoint here, and I don't see it on my thank you very much. I see it here. Just give me a thumbs up when you see it there, please. Thank you. All right, well, we're going to get started, and I know some folks might be coming in a little late due to the icy conditions out there, and my backyard was an ice skating rink. It was probably a rather amusing video to see me sloshing through the water with the ice underneath trying to get to the garage. So I'm glad to see you all here safe and sound, and hopefully you stay that way for the rest of the week, because I think that's going to be the overwhelming conditions. Want to get right started because we've got a busy day today. I want to review the medication administration worksheet and make sure that you understand kind of how to assess dosages and calculate dosages for pediatric patients. We have a respiratory lecture, which is important because when we come back after break, you're going to be having a simulation, and part of that simulation is a young person with asthma. So this is kind of foundational for that. And then we have a guest speaker coming in to present on GI and GU. So a lot to cover in one day. I realized that I don't think the module was open in Canvas that gave you the readings and stuff. Hopefully if you needed those readings, you got them from the schedule, but that module is now open. So I apologize for not realizing that that page wasn't published. Any questions before we get started? All right then, let's move right to the medication administration worksheet. Honest answers, just raise your hands. Who looked at it? Okay, good. So we've got some folks that should have some things figured out and can help me work through it. I appreciate that. But somebody that maybe didn't do it, try answering the first question, because this should by now probably be rote. What are those 6 rights of medication administration? Okay, I'm hearing patient. What else do we have? Medication. I heard dose, and now let's get 3 from Rochester.
Route.
Okay. Time.
Documentation.
Right. We haven't done it unless it's documented, right? Okay. And then I know that you probably have heard some other ones, but those are the main ones that we talk about when we talk about the 6 rights. And we're going to use those with kids too. So we always want to be looking at that wristband, or on a real small one, it might be around their ankle, but we want to look for that identification and make sure that we've got all that right. As I said in the past, if a parent or a child says that, they've never taken that medication before, what is that medication, that doesn't look familiar, double check yourself. It could be just that it's a different manufacturer of the same medication. It could be that it's a different one, and we need to double check it, make sure it's right, give them some teaching on it as well if the parent and child weren't aware that something new was being added or whatever. Pediatric dosage calculations, the second one, almost always based on weight. And it's important to remember that it's typically weight in kilograms. So a lot of times if we go around saying, my patient weighs 15 pounds, my patient weighs 15 pounds, we need to remember that to assess correct dosaging, we'll need to convert that weight from pounds to kilograms. And that's our friendly 2.2 divisor, right? The most appropriate site for injection in a 12-month-old. Anybody look that up? Anybody find out what that was?
Vastus lateralis.
Right, I heard it from a bunch of folks. Vastus lateralis. If I could spell. And do you know why that is?
Big muscle.
Right, big muscle. What's that?
But not a lot of nerves.
Big muscle, not a lot of nerve, so it's an ideal site because we're more likely to get into the muscle. And what do we remember from our musculoskeletal growth and development that a 12-month-old has been working out? They're working on their upper body or lower body? Right, they've been more working on their lower body, right? They've been working on pulling up to standing and things like that. So it's a big muscle, and it's going to be a more well-developed muscle because developmentally they've been working on getting those legs stronger to support them in standing, into movement and crawling, and then to actually begin to walk. And all of that work has been developing those lower extremity muscles. So it's a large muscle, away from nerves, and it's a more well-developed muscle in a 12-month-old than a deltoid or something like that that is typically used with adults. Make sense? A 3-year-old child can swallow pills. I heard some of the answers here. But that would be false. Typically, 3-year-olds, we say about 5 or 6, right, where they may be able to swallow pills. And sometimes you're never able to swallow a pill. Or, people have difficulty swallowing pills sometimes for a long period of time. But typically, a 3-year-old, we would not anticipate they could swallow a pill. If it was something that wasn't available in a liquid form, or that could be, if we could crush it, that would be okay. Otherwise, we might have to find a different kind of a pill. Or, different medication. Child age, maturity, and weight modify the absorption, distribution, and elimination of medications in children. Okay, that's a true statement. We went through some of that last week and how that worked. But what were some of those issues? Anybody remember any?
Their kidneys.
What was that?
Kidneys and liver developing.
And they absorb it faster normally.
They say their body fat.
What was the next one? Something about,
The percentage of body fat that they have.
okay.
In order to absorb faster with another thought.
Elimination.
Less body fat. What about elimination? Tell me a little bit about that.
Well, their renal isn't as.
Okay. Yep. kidneys and liver, more immature. What do we know about their body surface area in proportion to weight in adults? Yeah, typing this morning's not going too well. Okay, their blood-brain barrier is less mature, so it's more immature. They have a greater percent of fluid per weight. They got more water on board. So all of those things would influence that absorption and the metabolic rate of absorption of those of medications. So when putting an oral medication in formula for an infant, it is better to dilute in a small bottle or mix with 1 to 2 milliliters of formula. And figure a small bottle is probably 3-4 ounces. Any ideas which would be preferable?
Mix the smaller amount.
The smaller amount, right. And why is that?
You might not finish on the
Make
bottom.
sure they eat the whole thing. Did you hear that?
No.
To make sure they eat all of it or take all of it.
Right. Right. So we want to make sure that they get all the medication. And if we put it in a small bottle of, say, maybe 3 ounces of formula, and they're not really hungry and take an ounce, how much of their medication did they get? We don't really know. So mixing it with a very small amount of some sort of a liquid would be preferable.
To mix it with their food, wouldn't it kind of, if they don't like it, they associate their food with medication? You know what I'm saying?
That's a great question.
I do know what you're saying, and this is one of those questions where this may not be the ideal answer, but given the answers that you're provided with, it's your best choice.
Okay.
So yes, if you could avoid mixing it with formula and using water or something else, you're absolutely right. You don't want them to develop a food aversion because they're so used to it containing their formula and it tastes bad that now they're not going to take formula. That's the other reason why you don't put it in a bottle or you don't put it in something that's associated with feeding necessarily in a young child, because that association would be made too. So really good point. Oral liquid medication for administration to children should be measured using a a syringe, because we can get really exact, especially with like those tuberculin syringes that are 1 cc, so you can really get very specific with that dose for a little child. And then also giving an oral medication with that syringe is really easier. You don't then have to worry about it being on a spoon and the child jerking or something like that. You can get the syringe into the side of their mouth and dispense the medication, and then they'll swallow it. Unless they spit it out at you, but hopefully they'll swallow it. Oh, I think I jumped ahead. So number 8 is actually the 1 cc syringe as well. So depending on the dose that's required, you could use a 2 or 3 cc syringe if that's the amount of medication that was needed for liquid medication. Type of syringe that you would need to deliver oral medication that's less than a milliliter is the tuberculin syringe, because that allows you to do those measurements. Questions? Once a pill's crushed, what would you mix it with to administer to a child? Okay, some sort of maybe juice, maybe formula, maybe water, some sort of fluid or something that it's going to mix with, and they can take it.
Can you do like applesauce or yogurt or not yet?
You could. I actually had a 6-month-old, and we'll talk about cystic fibrosis a little bit later today in the lecture around respiratory, but children with cystic fibrosis also have a lot of times their pancreatic enzymes aren't excreted like yours and mine are, so therefore they have absorption problems. So they take enzymes. And have any of you had adults with cystic fibrosis you've taken care of and things like that? If not, they have to take enzymes with any meal that they eat, any food that they eat. So we had a little one in the hospital, about 6 weeks old with CF, and at this point I was teaching, and one of my students came to me and said, I'm going to give the baby lunch. Mom showed me everything to do. I just need to mix the medication with applesauce. I was like, a 6-week-old is now going to have applesauce. It had never crossed my mind how newborns and infants diagnosed with cystic fibrosis get their enzymes. And at that point, we didn't have liquid enzymes, so they actually would break open the capsules, put it on a little applesauce, and kind of present the spoon to the mouth, and this infant would kind of lap up and eventually get all their enzymes, and then they would be able to take their bottle. Not advisable for just any 6-week-old. That would be something that we would hopefully have something that we could crush, or a liquid formulation that the pharmacy would provide, that we would give a 6-week-old their medication. But in some instances, they can actually mix with applesauce. So yeah, applesauce would be an okay for infants that were already taking food by mouth. And then I would check with what they've had, what allergies they have. You'd want to go through all of that. I wouldn't want to introduce applesauce newly to a child in the hospital if they have never had it before. Make sense? So mix this with liquid or food. But you don't want it to be something that becomes an aversion to them. So you need to kind of weigh what they like and what they don't like. What kind of oral meds don't we crush? All right. How would you hold a toddler to give an IM injection? Any ideas?
Have her sit on her mom or dad's lap.
What's that?
You could have her sit on her mom or dad's lap.
Okay, and what are we going to ask mom or dad to do?
Have them hold the site still.
Right. Maybe hold their hands and arms maybe give them a hug, so that's kind of restrained. Maybe hold their legs kind of in between your legs so that they're a little bit kind of constrained at least. But yeah, having the parent hold the child is a great way to kind of physically help to hold them and avert any inadvertent kind of pulling away without, having to get 6 people in there holding down limbs and things like that. So the gentlest way possible is always a good approach. All right, now getting to the good stuff. A physician orders 250 milligrams of phenobarb for a 5-year-old child who weighs 20 kilos. See, now this one's nice. They give us the weight in kilograms. The recommended dose is 100 to 200 milligrams per kilogram. Phenobarb comes in 65 milligrams per milliliter. So the first question asked is this a safe dose? So how would we determine if it's a safe dose? Can somebody in Rochester walk us through that?
The safe dose would be 10 to 20 milligrams per kilogram. So you would multiply the child's weight in kilograms by 10 to 20 to find the safe range.
Okay, so 10 times 20 is?
200.
And 20 times 20 is? So is it a safe dose?
Yeah.
Okay, so the dose is between 200 and 400 milligrams. So safe or sage. And how much would you give? How do we figure that out? So we want to give 250, right? And we've got a bottle of phenobarb that tells us that it's 65 milligrams per milliliter. Divide what by 65? 250 divided by 65 equals, did somebody do it?
3.8.
3.85? Right, so that's the calculated dose. Good. Questions about that? Everybody see how that works? No questions on that. Is 2 milliliters a reasonable volume to give an injection for a 6-month-old?
Can we round that last one up to 3.9 then? Would that still be right?
Yeah, when you're measuring it, depending on what you were using to measure, if you've got one that you've got 3.8 and 3.9, you could look to get just a little in between, but you're going to give between 3.8 and 3.9. Absolutely. But if you ask for the calculated dose, it's 3.85.
Okay.
And if it was a really small infant and your dose was 0.85 mLs, you'd use a tuberculin syringe to measure that out. Two milliliters, reasonable or unreasonable for a 6-month-old, an infant? That's too much. Again, when we think about their bodies and their muscles. A 6-month-old, not really well developed. So the most we would want to give to a newborn to about a toddler is about a half an ml to 1 ml. So that 2 mLs would not be a reasonable dose for an IM injection. And so that's a newborn to toddler. Preschool, so 3 and up, you're going to give anywhere from 3 to, or a half to 3. 3 mLs would be the largest dose. And again, you would not probably give a 4-year-old a 3 ml shot, but it would just be kind of work its way up as the child gets older and larger. Tylenol and Motrin for our pediatric clientele are going to be really common medications, both given in the home and in the hospital. Really important that we give safe doses. We know that toxicities can happen if kids are given too much. And again, what we know about their systems, there's less give and wiggle room with our pediatric patients than there are with us as adults. So really, really important to make sure we're not overdosing them. So the common dosage for Tylenol is 10 to 15 milligrams per kilogram every 4 hours. So what would you expect to be an appropriate dose for a 6-month-old who weighs 7 kilos?
80 to 105.
70 to 105. Can you tell us how you did that?
I did 7 kilograms times the 10 milligrams per kilogram and then times 15.
Okay, so 7. So that would be your expected dose. You would expect to be giving somewhere between 70 and 110. 100. My math is not. Everybody see how that was done? IV medications should always be diluted in 50 milliliters and run over at least 30 minutes in children. True or false? Run over 50, not at least. Run over 50. True or false? What do you think? Even if you don't know anything about meds, what do we know about children? Why do we know it's false?
We just talked about how usually you do like 1 or 2 milliliters and 50 milliliters in 30 minutes.
Okay, so 50 milliliters in 30 minutes for a real tiny baby would probably be too much. So that needs to be considered. So when I said at least, that left the door open for that being a true question because at least 30 minutes, yeah, but I could run it over 5 hours. But again, that's probably not the way we want to give a medication. So that diluent needs to be considered. Okay, let's talk a little bit about calculating fluid needs. So if we have a child who's NPO or not eating because we're getting them ready for surgery or something like that, or maybe they've got a bowel obstruction, but we're not giving them any fluids, they're not taking in any fluids, but we know that the body is still processing, clearing, and so they do have minimum daily fluid requirements. The way we calculate that and figure that out is based on this chart. And what it does is it takes into account the child's weight and says for the first 10 kilograms of weight, we allocate 100 milliliters every 24 hours. So if I had 100 milliliters per kilogram per every 24 hours. So if I had a child that weighed 10 kilos, over a 24-hour period, I would want their IV to run at 1,000 over that 24-hour period, right? So 100 times 10 gives me the volume per 24 hours. Yes, makes sense? So if I had a child that weighed 7 kilos, how much fluid would I want to run over 24 hours? Speak up. 700, I heard here. Folks in Rochester agree with that?
Yeah.
Okay. And how would I find out what my hourly rate was? What do I set the pump to?
Divide by 24.
Right, so 700 divided by 24, whatever that would come out to, would be my hourly rate to make sure that that child was getting enough fluid on an hourly basis to cover their needs. If the child weighs more than 10 kilos, we're going to cover the first 10 kilos of their body weight at 100 milliliters per kilogram per hour. But for the second 10, so anything over 10, between 10 and 20, is going to be covered at 50 milliliters per kilogram per hour. So if I have a child that weighs 15 pounds, or 15 kilograms, let's just stick with kilograms, 15 kilograms, how much volume am I going to give them over a 24-hour period? Anybody? $12.50, I heard here. Anybody concur or get something different? So can you tell me how you got that?
So it's
Speak up.
it's 5 kilos above the 10, so you take 5 times the 50 extra per kilo.
Okay, so 5 times 50 is?
Or I mean, yeah. 5 times 50 is 250.
Is 250. And then we add that to the
Baseline 1,000.
for the 1,000 because they weigh more than 10, right? So we've got that covered. Does that make sense to folks? So how much volume would we want to give over 24 hours to somebody that weighed 20 kilos? We love math, I know we do. So if somebody weighed 20 kilos, they would get that 1,000 milliliters to cover the first 10 kilos of their body weight. And for the second 10 kilos, it would be 10 times 50, which is 500. So over the course of a 24-hour period, we'd want to see that they get 1,500. And then it's the same principle for if they weigh over 20 kilos, they would have 1,000 milliliters to cover the first 10 kilos, 500 to cover the second 10 kilos, and then whatever they weighed over 20 kilograms, we would multiply that times 20. Figure out what that incremental was. So for example, if they weighed 25 kilos, we would have 1,500 plus 5 times 20, which is another 100. So they would get 1,600 over the course of 24 hours. How many people did I totally lose? Okay. We will see this.
How can we see it get worked out?
What's that?
A couple of people here get it, but they're getting a different answer, and they're wondering if possibly you could just work it out really quickly, or
So we can see the numbers get worked.
see the numbers real quick.
Sure. So if a child weighs 7 kilograms, 7 times 7 kilograms, we'll do this, 100 milliliters per kilogram per 24 hours equals 700 milliliters per 24 hours. Yes? If a child weighs 15 kilograms, first 10 kilograms equals 1,000 milliliters per 24 hours. Additional 5 kilograms equals 5 times 50, 250. So therefore, $1,000 plus 250 equals 1,250 milliliters in 24 hours. Yes?
Okay, how is that for you guys? How many of you guys are understanding that? You guys got it? How many are not?
For the
Say it loud. Say it loud.
for the point 3, do we just, for the original question, do we want to keep the point 3 in the question, or do we want to keep it rounded down to just that whole number?
A good question.
Oh, you would keep the point 3.
We keep the point
So
3
for
open.
for the question, you would take 1,000 plus 50 times 5.3, which is how much? So what's 50 times 5.3?
Yep.
265, yes?
Yep. Exactly.
So the answer to that would be 1265 milliliters in 24 hours. Yes? Questions? Everybody good? Okay. As I offered last week, if anybody needs some kind of refreshing with calculations or just isn't, has math phobia, I'm more than willing to sit down and we can work through some other problems, and want to see everybody get nice and comfortable with working through medication dosages and calculating, how to figure out if your patient's on a good 24-hour rate, how to convert from pounds to kilograms, and all those kinds of good things. I will open up, after class today, a key to this worksheet so that you can see the answers for your studying purposes. And again, any questions you have, let me know. Sound good? Okay. We're now going to, we'll cover that at another time. Let's take about a 5-minute break to just kind of switch our brains and get a little stretch. And it's probably a tough morning getting in, and this is not an easy way to start the class either. So let's, I'll take a deep breath, and then we'll come back and talk about breathing and respiratory. All right, let's come on back. Can somebody just pull the door shut? Thank you. right. Take a deep breath. And out. And another one in and out. Respirations. What more needs to be said, right? We breathe. Air goes in, air comes out. That certainly is one part of our respiratory condition, right? Our ventilation. What's the other part? Why do we breathe in air? Gas exchange. Gas exchange. So the other part of respiratory, ventilation is one, and oxygenation and that air exchange, right? Oxygenation is the second. We need to take in oxygen and get rid of our carbon dioxide. So we need to do a little bit of thinking about our respiratory system and how our respiratory system differs with our pediatric population. So we're going to talk about some of the pathophys for pediatric common respiratory diseases. There's some links to breath sounds, and we'll talk just a little bit about breath sounds in our pediatric population, some common meds that are used, and interventions. So our normal respiratory assessment. If you remember, we look, right? What's the appearance of that patient? How do they look? How do they sound? We percuss. What's my fourth? Look, listen, touch. So we're going to do all those things with our pediatric population. With breathing, with listening for respirations, how long do we want to listen to respirations for an infant? Right, a full minute. And it's easiest to do when they're not crying, not laughing, not doing things like that. So if you can get to their chest when they're more of a quiet person, or if they're sleeping, warm that diaphragm and bell of your stethoscope and get under to do that. Now, when you inspect, you are going to have to actually look at their chest, because you want to look at that chest movement. But basically, you're going to follow the same kind of an assessment that you did with your adults. And here you can listen to some of those breath sounds just to remind yourself what they listen to. We're not going to take time now because I've got nearly 60 slides and about an hour to get through them. The pediatric upper airway is different. Proportionally, we've got a larger head, right? We remember our toddlers, when we look at them, they're top heavy, right? It's because their heads are so big and their bodies are still catching up. So proportionally, the head and the occiput are larger. If we remember, up until about the age of 6 months, our infants are obligatory nose breathers, right? I think we talked about that in mother baby, in feeding. It's a good thing that they don't want to breathe through their mouths because they're trying to feed. But what that means for us when we're talking about respiratory is anything that's going to clog your nasal passages. So if that infant, when you think about how tiny that newborn, that infant is, and you think about how proportionally tiny their nares are, the nasal passages, the bronchioles and the alveoli, any swelling, any extra mucus and things like that really cause havoc with their breathing. And that's why we try that's why we keep their nasal passages so open, because they don't know to breathe through their mouths. They don't know they can do that. That's not an instinct that we have up until about the age of 6 months. They have a smaller jaw, a larger and more flaccid tongue. So it's floppier, it can get in the way more. The larynx is more toward the front, more anterior, and it's also higher. So as compared to an adult, you have a shorter trachea. The epiglottis is larger and more floppy, which is good because you want it to be covering that airway, but it's bad because there's not then a lot of room for swelling, which we'll talk about epiglottitis, which is really a medical emergency. And because their epiglottis to begin with is larger, if it becomes inflamed and edemic, it can occlude the airway. The cricoid cartilage is the narrowest part of the airway. Typically in adults, we have a pretty cylindrical trachea and airway. In our children, it slants inward, and the cricoid is the narrowest part. And then the other thing is we've got loosely attached mucous membranes, so they are not as firm, so they can move. Also, the cartilage in our infants is much more pliable than ours is, so that it's easier for, if there's increased airway resistance, for retractions and collapse of airways. As we said, the trachea is smaller, and because it's smaller, your bifurcation into the lobes is higher. And so they're going to get longer before they get wider. So up until about the age of 5, they don't get wider, they just grow in length, and then they start to expand in diameter. We have distal bronchioles that are fewer than adults, and they're growing, so they've got them, but they're not as mature, which is pretty much the typical standard for all of our pediatric patients. The alveoli begin to increase in size and complexity after 8 years of age. That's a long time. And under 6, the diaphragm is flatter, so there's less ability to increase volume. And so when there's less ability to increase volume, if you need to increase your ventilation or your oxygenation, the only way you're going to be able to do that is by rate, because you can't create that extra volume that's needed. And here we see a picture of that newborn as opposed to the adult. You can see how it's less of a distinct V. So it is flatter. So when we, excuse me, when we inspect the chest of our pediatric patients, we want to see pretty typical normal respirations, right? Like we would with our adult population. We want to see an even rise and fall. And for our infants and toddlers, it may be more of an abdominal rise, because that's the other thing, is they're abdominal breathers, they're not chest breathers, whereas with adults we typically see a chest rise. So in younger children and infants, we'll see that abdomen being rising. We'll look for retractions. Never a normal sign, always a cause for concern. That means there's a real increased work of breathing, increased resistance, so I'm really having to work in pulling air in and out. And where we see a lot of retractions is where we would see it in adults too. Suprasternal, supraclavicular, intercostals, and the intercostal muscles are not really well developed in our infants. So if we see retractions intercostal, that really is a reason for concern, because they're really working to breathe. So we want to look at that general appearance, right? We know that acrocyanosis in a newborn is a typical observation. But after that, we don't expect to see cyanotic nail beds, right? We expect to see good cap refill. We expect lips that are and oral mucosa that's pink, and things like that. We don't expect to see any retractions, no nasal flaring and things like that. So you want to look at that appearance and note what is abnormal and what you're visualizing that might indicate that this individual is having a little bit of respiratory distress. So you want to note the skin color. Circumoral is never a good sign. Even if it's a newborn and they've got acrocyanosis, if they've got more generalized cyanosis, not good. Respiratory rate, and this is why it's really important to know for our pediatric population what those standards and what the typical rates are. Because we need to know if a rate of 50 in a 7-year-old is typical or not. We need to know if we've got a newborn that's tachypnic at maybe 80 breaths per minute. Is that typical or not? So we need to know normal so that we can identify if we've got a respiratory rate that's either too high or too low. Kids will compensate. So being tachypnic, being tachycardic is a response to a problem or a challenge on the systems, but that's a compensatory challenge. Brady is more of a concern because typically that for our pediatric population, and especially our little ones, means they're just punking out. They've done as much as they can. Their bodies have compensated as much, and now you are typically heading toward a code. So we want to look at their respiratory rate and assess it versus what is typical. The work of breathing. Are they, does it look like they're having to work hard? Are we seeing those retractions, those use of accessory muscles, nasal flaring? Are they grunting? And if we remember, grunting for breathing in the first hour of life is typical. After that, we should not have to actually make sounds to breathe. And that typically means that there's really a lot of work going on to breathing. So we want to assess that work of breathing. Then we want to listen to those breath sounds and see how they sound. Are they wheezing? Do we hear breath sounds throughout the lobes? Did we hear breath sounds at the beginning of our shift and now we're not hearing breath sounds in the lower lobes, or what's going on? So knowing and doing that initial assessment, and then so that we have our standard and know if things changed and what the lung sounds are. We want to get some sort of a PO2 reading. For our pediatric patients, the least invasive is like a pulse oximeter, for our adult patients. It typically, for our little ones, is an adhesive that wraps around the nail bed. You don't want to wrap it too tight. Typically, you might see it on a toe instead of on a finger. When you think about our infants and young children, playing and doing things with their hands is really important. To have something on a finger that's impeding that will, number one, create a lot of artifact. Number two, create a lot of chances that they'll want to just take it off. Whereas if it's on a toe with a sock covering it, chances are it's going to stay on longer and you'll get better readings. What are other ways we can assess oxygen saturation? Have you seen oxygen saturation assessed in any of your adult patients other than a pulse oximeter?
You can have an ear probe, like a ear clip.
An ear clip? We're kind of on the same principle as the pulse oximeter. It's a hearing blood filled. Anybody been in an ICU, seen blood gases taken? one of our components for a blood gas, whether it's arterial or venous, is a PO2 level. So we can monitor, that's much more invasive. If somebody has an A line, we can draw blood gases from that line. But if we need to stick them, that can be a really painful kind of a stick. But we can look at O2 saturation in a lot of different ways, and it just depends on the criticality of the patient and what's ordered. I think we've talked about symptoms of distress a little bit already in the assessment, but we're going to see retractions, nasal flaring, rapid breathing, shallow breathing, grunting sounds. So if we hear those, if those are the kinds of things that we're observing and assessing in our patient, we don't want to sit on that, right? Because we can say, oh, well, but their O2 sat's good. Well, yeah, but they're breathing really rapidly, and the breathing muscles are going to tire out. And if those breathing muscles tire out, there's no other way to compensate. So we want to recognize symptoms of distress and react to them rather than let the child go downhill more and potentially need to call a code. When we see symptoms of distress, we want to understand what the underlying cause of that is so that we can address the underlying cause while we're maybe giving oxygen therapy if they hadn't been on any O2 and things like that. Key differences in the pediatric respiratory system: a lack or insufficient surfactant, especially in our premature babies, so we want to be aware of that. Surfactant creates the tension that keeps the alveoli open. They have smaller airways and underdeveloped cartilage, so those smaller airways just don't allow for as much. They're less forgiving if they're swelling, right? If I've got a tube that's 4 millimeters in diameter and it swells for 1 millimeter, I still have 3 millimeters of open volume. If I've got a 1 millimeter airway and it swells, I'm out of luck. So really, it's less forgiving for some of these, especially when you've got really, really small airways. And with that underdeveloped cartilage, it's easier for a collapse of a lot of the airways. Our infants, being obligatory nose breathers, definitely under the age of 6 months, is a big, can be a big problem, especially think about when you have a cold. What gets all clogged and snotty, right? Your nose gets plugged up. You can't breathe through your nose and you breathe through your mouth, and we don't give it a second thought. But if you were under the age of 6 months and you had all of that upper airway congestion, you may not be able to breathe. You may be really struggling, and so keeping that nose clear is important. Less well-developed intercostal muscles we talked about. The newborn may have brief periods of apnea, which if you've got some respiratory distress can exacerbate. They have faster respiratory rates and increased metabolic needs. The other thing that happens with faster respiratory rates is we have more sensible water loss, right? Because the more we're breathing in and out, the more we've got kind of dry air. If you've got a cold and you don't have humidified air and you're breathing a lot through your mouth, you know how dry your mouth gets. Well, that's how for infants it is. The eustachian tubes are more horizontal, so when you think about an infant lying down and feeding and having those horizontal eustachian tubes, it's easier for formula or milk to migrate into those eustachian tubes. Their tonsils are larger, and again, why tonsillitis can be such a problem. If you've got large tonsils to begin with, and now you have tonsillitis, so they become a little bit more edematous, now they're more of a problem, and I think there may be a picture in your book of tonsils that are almost touching. Not a good situation. So we need to be aware of these differences. And the larynx is more susceptible, more flexible and susceptible to spasm. So with some of our upper airway inflammations and things like that, we need to be aware of those. When we think about the enlarged epiglottis, the narrowing of the airway down into the cricoid, foreign body obstruction is a big risk for our pediatric population. If we think about any of those toys with small parts, it's always under the age of 3, not recommended, do not use with under the age of 3. The problem is our kids under the age of 3 often have older brothers or sisters who have these toys and things like that, so they're around the house. Children like to explore. They explore with their hands, they explore with their mouths, so everything, toddlers, infants, from hand to mouth. So we need to be aware, actually, in their mouth, in their ears, in their nose. And so it just becomes a real hazard for foreign bodies to be in, for them to just, I stuck a penny up my nose. There's no reason, there's no rhyme. At that point in time, it seemed like a good place to keep it. So, we just need to be watchful, think about these things if we're caring for the child. Also, it's part of the teaching that we do for parents as the child grows and develops, making parents aware that these are risks for children, and we don't recommend these kinds of things. They don't have molars yet. When you think about the formation of dentition and how teeth come in, they come in from front. So they don't have molars, so they can't chew really well. So mastication isn't as well developed as it is for you or I. So giving a large piece of, say, meat and expecting them to be able to chew that into a mush to be able to swallow is not an expectation we would have of our younger children. If they have any history of choking or dysphagia, problems in swallowing or things like that, we would want to be aware of that. If we have a child, the universal choking sign is pretty universal, and it's almost an instinct that when you can't breathe, you do this. So we would want to be aware that if a child, looks like they're choking, if they've had a typical sounding voice and now all of a sudden they're really hoarse, that may be something that's obstructing the vocal cords. So really, doing that assessment and listening high and low in the fields. Any obstruction for a child is a medical emergency, requires airway protection and would require emergency intervention in order to maintain, stabilize, and then remove whatever's occluding their airway. Any questions on kind of the anatomy, the differences between adult and child? Okay, so we're just going to go through some of the alterations in the respiratory system that can happen to children. And the first one we're going to talk about a little bit is otitis media. And that's when there's an effusion or an infection that blocks the middle ear. So it's acute if it kind of has a sudden onset and it's associated with other signs of illness. So a lot of times, there's a sore throat or the child's been running a fever and they go into the pediatrician, they have an ear infection. A lot of times it's in conjunction with something else, but that would be an acute one. Otitis media with effusion means that there's a presence of fluid behind the tympanic membrane without signs of infection. So that's just that buildup. It may be after an infection, but that buildup of fluid may take a couple months to resolve. So the ear would look not red, not infected, but it wouldn't be that, the eardrum wouldn't be that opaque kind of you'd see fluid behind it. I think we've got, a couple pictures. So A is a pretty typical one. B and D look a bit inflamed, right? They look red, and you can see D looks swollen, can't really see. And then in C, this effusion, you can see some fluid with bubbles behind it. Now, I know you guys don't look at tympanic membranes, do you? You're not? No. But advanced practitioners would and would see that. When I was in nursing school, I actually had to do an assessment and got my good friends had a son, and so I was doing his ears, and it looked like he had little pieces of paper stuck in his ear. And I was like, okay, I'm a student. I'm not sure what I'm seeing, but Brian, did you stick paper in your ear? And his mom's like, no, he's had so many ear infections, that was scarring. That was scar tissue on his eardrum. So it really can be problematic for kids that have a lot of ear infections, can hamper hearing at that point in time and in the future. It can hamper the development of speech in our really young kids if they've got a lot of effusions. When you think about having fluid behind your eardrum, what do we know about sound going through fluid? Gets muffled, right? So you don't hear as well. So if you're an infant trying to learn how to speak and you're not hearing sounds clearly, that can really hamper your development of communication. One of the things that we do when we are concerned about infants developing speech development is we have hearing tested. And now you know we actually test hearing at birth because it can be such a problem when it's not picked up early, and it can influence their development of speech that otherwise would happen without issue. So otitis media, acute otitis media, you may see febrile. Sometimes it's just the uncomfortableness of the ears, so there may be some tugging and pulling at ears, some just trying to, just looking uncomfortable. And things like that. When the tympanic membrane is visualized, it might be bulging. As we saw in those pictures, it could be reddened, erythematic. You can actually, there's an implement that you can put on the device when you're visualizing the tympanic membrane to just put a little puff of air, because we know that the tympanic membrane picks up the vibrations of sound, and that's how we hear. And so it needs to be mobile, and it needs to be moving. And so you put that little puff of air in, and you see if it's mobile or not, if it moves. And so you would see decreased mobility in a lot of those situations, which means that it is impacting their ability to hear. When you think about if you've had ear infections, you've had an earache and had an ear infection, if it has impacted your ability to hear, it can be really annoying. And then if the tympanic membrane bursts and there is an infection, the pain goes away because now that pressure differential is resolved. So kids that might have been screaming at the top of their lungs now don't scream anymore, but there may be drainage out of the ear. And if you're seeing drainage from the ear, that typically means that the eardrum is burst and it's relieving that pressure, and now it's draining whatever exudate was inside in the middle ear. So that's acute, as opposed to otitis media with effusions, which would be the more chronic, or that one that might last a couple months. So they may have impaired hearing. As it resolves, they may have like some popping sounds, which is the repressurization, almost like if you've been in an airplane that hasn't been pressurized really well, and then, or going up high into a mountain and then coming down and your ears pop. They may have those kinds of popping sounds, tinnitus or ringing in the ears. They may have some hearing loss. So if it goes on long enough without resolution, we know that the inner ear is responsible for some of our balance and proprioception, so they may have disturbances with that. And if they do have a tympanogram, because that membrane isn't as mobile, you would see a flatter tracing. Any questions about the otitis? Croup is really an upper airway condition, and often, it's coughing. It can a lot of times begin at night, and it can be, preceded by a child who's had an upper respiratory infection for a couple days, and now all of a sudden they've got this harsh, barky cough, sore throat. They're working to breathe, so you may hear some inspiratory stridor, because when you think about it, stridor is that upper airway breathing sound. So you may hear some inspiratory stridor. They may have hoarseness when they talk, using accessory muscles. When you think about kids, can't breathe, it's frightening. So they may be frightened and agitated. There may be some cyanosis. They find that sitting in a tripod position, which kind of helps them to extend their neck to relieve some of that pressure and get in a position that helps breathing easier. So that tripod position might be the position of comfort for the patient. And you can see here what happens is the tissue swells, and so you're narrowing the airway. And that's what's causing the stridor, that's what's causing that irritation, the coughing, and things like that. So sitting upright can be helpful. Croup in and of itself, upper airway, a lot of times with your basic croup, the parent will say, we went to bring them to the hospital because they were really struggling, they were coughing a lot, brought them outside into the night air, and they stopped. So that humidified cool air sometimes can be helpful. And so long as they're not cyanotic and things like that, we would watch it, but definitely, something that does need to be watched is that narrowing of the airway. If it becomes too narrow, can occlude their breathing. Epiglottitis is the other kind of croup, and it is a medical emergency. What happens when we look at the epiglottitis, the epiglottis, is it occludes the trachea. And so that epiglottitis that we know in our small children and infants is larger and floppier anyway, becomes inflamed. So that's where that upper airway infection is. And that can occlude the trachea. So here we see kind of where the epiglottis sits with the vocal cords and the cartilage and the trachea, and then what it looks like when it gets infected. So on the left, we see that this looks pretty open and unobstructed. We can see the vocal cords there, and it looks pretty good and clean. And then on this one, we actually see an ET tube. This child was intubated because the epiglottis is so swollen and so narrowing the airway that respirations, ventilation was not needed emergency intervention by intubating. So with epiglottitis, we don't want to do anything that would irritate the epiglottis, right? Because anything that's going to irritate it is going to cause it to spasm, is going to cause it to potentially become more edematous and occlude the airway. So if we see a child that we suspect that has epiglottitis, it's a medical emergency, we stay with them and we get help. So knowing some of these cardinal signs are important. So drooling. So this is so painful that the child doesn't even want to swallow. So you would have a child that's drooling, having difficulty swallowing, difficulty talking, and really is working to breathe and has a lot of respiratory distress. So you're going to suspect epiglottitis in that instance. You do not want to look. You're not going to say, oh, open your mouth, say, let me stick a tongue depressor down there and see if I can see how red and swollen you're. Stay away. Okay, because any spasms could cause an occlusion of that trachea. So we don't want to leave the child unattended. We want to help the child and the parents remain calm. And we want to get help because we are going to anticipate this child might be intubated. And then here on the right, we see kind of what we would do. We want to decrease their anxiety. We want not to examine the throat. Position for comfort, so however they want to sit and be comfortable, that's great. We don't need to insist that they sit one way or another. We would ask to get trays ready for either intubation or a tracheostomy, because that may be the emergency intervention that's needed. We could apply a cool mist humidified O2, so that would be appropriate. We wouldn't want to give any fluids by mouth. If the child's on an IV, we probably would want to start running some IV fluids. Here we see a little guy that's in some uncomfortable respiratory situation. Over 6-month-old, so he is definitely breathing through his mouth, but doesn't look like he's doing much of anything but that. Tripod position, we can see a little bit of increased pressure in the abdomen to increase the effort of breathing, and then bending over a bit. There's another example of it. And another, I get to breathing consciously when I talk about respiratory stuff. And then you'll hear about other types of croup, other types of airway, upper airway conditions with kids. Laryngitis is one, bacterial tracheitis is one. So there are a bunch of types of conditions that fall under the umbrella of croup, and it really depends on where in the upper airway it's affected. So tracheitis, here we see the trachea, we see how much shorter and how much flatter those bronchiole are. Yes, question?
In the module this week to focus on acute asthma, laryngitis, and then epiglottitis.
Epiglottitis, yeah.
Yeah. And then are those the only two you want us to focus on? Because there's two more listed here.
I think the advice to focus on something means kind of exactly that. It's not to say that you should be aware of the others, because certainly ATI might cover the others, and trying to give you a little bit more structure to what you might study for an exam. Did folks in Rochester hear that question?
No.
Okay, sorry about that. I realized that I had you, I think I might have you muted. The question was, in the module outline, it says to focus on acute croup, epiglottitis, and acute spasmodic. And there are two others listed, and kind of what did that mean? And my response, I believe you heard, was it's kind of putting you in the right direction, not to say that the others aren't also fair game, but where I feel more of the emphasis should be placed. So for treatments, as you saw, a lot of times it's cool humidified air, broad spectrum antibiotics. We would want a culture before that, if we can get a culture. Again, if we suspect epiglottitis, we're not going to get a culture because we may need emergency intervention before that, but typically We get a culture, then start antibiotics so that the antibiotic isn't impeding growth of what the underlying cause of the situation was. Endotracheal intubation is frequently required for stabilization of airway. So that becomes our number one, right? We want a stabilized airway. We want to ensure that we've got good ventilation and good oxygenation. And close observation in a unit with expertise in pediatric airway management. Because as we've seen from the first bit of the lecture, pediatric airway management, pediatric airways are different than adult airways. And there are some things that we would ride out in adults that we don't kind of typically just ride out in our children. So that's kind of looking at the upper airway. Now we're going to transition to the lower respiratory system, where we get, again, some of the conditions that I'm sure we've all heard about: bronchitis, pneumonia, pertussis, BPD, cystic fibrosis. We're going to kind of key on some of those. But these would be with the respiratory system. So bronchitis, inflammation of the bronchioles. The main bronchi, it can primarily be viral. So what that means is it's going to just need to run its course in most of us. You can have a dry cough because it's lower. It's not that upper airway congestion, so you're not going to have that necessary productive cough. That coughing can, and how many of us have coughed so much that our ribs hurt, right? You just get that persistent cough, and after a period of time, it's kind of like, I don't want to cough anymore because it hurts, but my body is still telling me to cough. So symptom management as the virus runs its course is typically the management strategy. It's a common cause of hospitalization in kids under the age of 2 because they have such secretions and inflammation in the airway that the mucus gets trapped, can't get moved, and it just causes them to develop a pneumonia-like situation in their lobe of their lungs. So a bronchiolitis would typically be accompanied by tachypnea, a cough, maybe some rhinorrhea, wheezing, and nasal flaring. So they're working to breathe, and we know they're working to breathe by the wheezing, by the nasal flaring, and by the retractions that we might see, by the tachypnea that we observe. RSV, respiratory syncytial virus. Anybody heard of it? Anybody had it, been diagnosed with it? Okay, we have one person diagnosed with it. Are you willing to tell us kind of what your signs and symptoms were?
I was like a baby. Well,
okay. Is our overhead mics on? Please.
Yeah, I was a baby when I was diagnosed with it. I think I was like maybe 6 months old. So I don't really remember. I think my mom told me I had it once and I was like, oh, okay. But yeah, I don't really remember much.
Do you know if you were hospitalized because of it?
I don't think so, no.
Okay. Anybody else diagnosed with RSV that remembers being, okay, in Rochester I see third row on the right. Yes, you, hi. Sarah, sorry.
That's okay. I was also diagnosed as a baby, but it was before I was 6 months old, and I was hospitalized, and then I got hospital-acquired pneumonia.
Oh.
So I was on oxygen for pretty much the first year of my life.
Wow. And did your parents tell you kind of what it looked like or what it was?
Well, the reason my mom took me to the doctor was she was like, the baby looks kind of purple. I don't think that's normal. She took me to the doctor and they were like, hey, go to the hospital.
Good observation skills on mom's part. Yeah, a lot of times, you know, it's a virus and it's all around us. And for adults, it presents like a common cold. And it just runs its course and things like that. But on infants, and especially on our immunocompromised pediatric folks, it can be life-threatening. And as in the case we can see, anytime you're admitted to the hospital, you're given interventions that can help support whatever you've been diagnosed with, but there's always a risk of a hospital-acquired secondary situation. But it looks like things worked out. You're not on oxygen now, Sarah, so those airways grew, developed, and any residual asthma or anything like that?
I've never been diagnosed with asthma, but I've had respiratory problems my entire life.
Okay, yeah, because a lot of times it can, but so RSV for our, under 2, under 3 population can be extremely dangerous because it's handling all those secretions. For our immunocompromised or chronically ill children, it is especially a risk because anytime they get any kind of an infectious process, it also exacerbates whatever their underlying condition can be. So for that population, it's often recommended that they get a vaccine during the winter months. So often between October and maybe April. Syncytial is a vaccine, an immunoglobulin that helps fight an RSV infection. It's given monthly. It is an injection, and it costs about $200 per dose. $2,000 per dose. So a lot of insurance companies in the past have fought parents and physicians who prescribe it for kids, and it's been one that has been had to advocate. The parents and the physicians have had to advocate for each and every dose that a child would receive. And if insurance companies were changed, parents would oftentimes just dread that because it would be one of those situations where now I've got to fight another insurance company to get this dosage for my child. That I understand is getting better. And Syncytial certainly does work wonders for that population in kind of helping them develop some resistance to RSV. RSV is highly communicable, so on our gloves, on our person, on countertops and things like that, it lives for a while. It's transmitted through droplet. So if we have a patient that's diagnosed with RSV, we want to be very diligent about gowning, gloving, universal precautions, hand washing, and all of those kinds of good things, because we don't want it to spread from patient to patient. We also would want to advise families also to be very careful and diligent.
Don't care, everybody, just kidding.
Questions? Question, yes.
I just have a comment. At Mayo now, they're not putting them on precautions unless they are like under a certain age or immunosuppressed. Like our adults that aren't immunosuppressed don't get droplet or contact precautions for RSV.
I'm sorry, who's not being put on precautions?
Like, I think it's just not, like, pediatrics are and immunosuppressed people are, but the adults are not anymore.
Right.
They were, but now they are not.
Oh, okay.
I just thought that was, I don't know.
Mm-hmm.
Because isn't it, I mean, I don't know. I just thought that was weird. Yeah.
Yeah, I don't know what their rationale or the science behind that would be. I know a lot of times hospitals just have a general policy is if you have any signs or symptoms of cold during this season, don't come. But yeah, that is interesting. But for our kids, we definitely have precautions and don't want that transferring patient to patient. So here we see just a little bit more of the information about RSV. It's a significant cause of hospitalization in children under the age of 1. It's highly communicable, contact isolation, droplet, and scrupulous. Okay, so we covered most of that. Moving down into the lungs, pneumonia is another alteration in respiratory conditions that we may see in our pediatric population. And we see here how normal alveoli have a lot of airspace, and with pneumonia, the airspace becomes inflamed, so the walls are thicker, so there's less area in the alveoli itself, and then they're fluid-filled or filled with exudate. So that hampers exchange of oxygen and carbon dioxide. Right, so we've got really two problems here. Is one, we've got less area to ventilate, and then we've got a oxygenation problem because there's a disruption. So really, pneumonia can take hold on two different fronts. Pneumonia can be caused by a multitude of problems. It can be viral, it can be bacterial, it can be a mycoplasm. We can have aspiration pneumonia, right? So I had trouble swallowing, or I inhaled when I should have swallowed, and now I've got a food or liquid in my lungs, and or formula or breast milk or whatever. So if we've got people that have swallowing issues that are taking in and aspirating a lot, that can create a pneumonia in the lungs, and it can also create a situation that's just very receptive of other bacteria growing because it's a dark, warm environment. And now, if it's a food product, you've probably introduced some sort of sugar in there. So it's just a really nice, warm, and cozy environment for bacteria to grow. TB, tuberculosis, is also a pneumonia kind of a condition. And treatment, again, would be supportive, would be treating the underlying. If there's a bacterial infection, appropriate antibiotics to fight it, as well as supportive care for respirations and ventilation. Sometimes it can be managed in the home, sometimes it's in the hospital on humidified air, and sometimes there's additional requirements for intubation and that kind of support. No. Okay, where'd we go? Whooping cough, pertussis. One of those that we've got a vaccine for, the DPT, can help with pertussis. But we know that our immunity wanes and that we can develop pertussis as adults. And if you've ever had whooping cough, again, this is one of those cough, cough, cough. I think it's been called the 100-day cough because it's just one of those that does not let up. I don't know why this is doing this. I'm going to do it that way. So we've got the initial symptoms can last for a week or two, and that would be just like a normal kind of upper respiratory condition where you've got a runny nose, maybe a low-grade fever, you feel a little punky, you have an occasional cough, but then it develops into these just coughing fits that don't quit. And again, it can be they can be rapid, hard coughs, hard to catch your breath during them. With our pediatric population, a lot of times they're coughing so hard they may throw up in the process, and it can be a high-pitched kind of a whoop when they finally take that breath in. It's it's exhausting, and like I said, the cough can last for a long, long time. Has anybody been diagnosed with pertussis or whooping cough that would be able to share about that? Okay, we do have one here in the Twin Cities, if our overhead mics are on.
I didn't have it, but my friend had it like the first semester of college, and she also has asthma. And she had the whole like throwing up from coffee, and it lasted like the whole semester almost.
You folks in Rochester hear that?
Yeah.
Okay, and did somebody in Rochester also have a story or whooping cough? Yes. Go
I
ahead.
had it my sophomore year of college. It was terrible. I think I cracked a rib from it, so I coughed so hard.
Mm-hmm.
The Department of Health called me after my test came back because it was a weird diagnosis. But, yeah, my roommates had to get prophylactic antibiotics.
Okay. So yeah, we didn't want anyone else to get it, and Department of Health, that's one of those that they track. And it's a public health concern. It is, contagious, and yeah, like here, it lasts for forever. Cracked ribs, I mean, not fun. And then you really don't want to cough, right? But we need to cough and things like that to help clear those airways. And I have one more here in the Twin Cities.
Oh, my brother had it when I was younger, and as soon as he was diagnosed with it, they immediately put our entire family on medication as well. It's like we had to be treated for it. No, we didn't, just because of the exposure.
Mm-hmm. So when there's close exposure, prophylactic antibiotics for treatment is given as well. We want to limit the transmission of the pertussis. Anything else in Rochester? So the DTaP or the Tdap vaccines can be given, and those are the recommendations there. Quarantine those that are contagious, so we don't want them out and about and traveling on an airplane anywhere or doing things like that. So during the contagious period, we would want quarantined, treating those that have close contact, so those that, in the family, those in the same dorm room or things like that, and identify and treat early. Like other conditions that we've got, those are, the earlier we can treat, the better we can control symptoms and the need for other supportive care. And again, just some clinical awareness. It's similar to bronchiolitis. If it's suspected, swabs are sent for pertussis studies and treatments begun. So we don't wait for those studies to come back. We start treatment if we suspect that it's pertussis. And like in everything, secondary infections, pneumonias, and things like that can happen. So we need to be aware of that. And that's, again, one of those reasons why treatment as soon as possible is necessary. And pertussis can cause death. Which is, so immunization is highly recommended for all. Cystic fibrosis, any questions on any of those airway kinds of issues that can occur in our pediatric population? Cystic fibrosis is a hereditary autosomal recessive disorder. It impairs the chloride ion transport, which means that instead of our the mucus being less viscous, it's a more viscous and sticky mucus that is produced in individuals that have cystic fibrosis. And as a result of that, the mucus that's in the linings of the lungs, the mucus that is in the pancreas, so all of that is impaired. and becomes stickier and is easier to occlude areas. And here's a photo that just shows the multi-organ involvement that a patient with cystic fibrosis has. We typically think of it as a respiratory condition, and certainly the lungs are one of the organs that are involved. And since our lungs are so crucial to our daily lives, that's what we associate it with. But we also need to realize that this mucus is throughout the body. So it is in sinuses. It disrupts the sweat glands because of that the chloride ion transport system being disrupted. So the way that cystic fibrosis can be initially diagnosed is through a sweat test. And what typically has been done is an area of the patient will be wrapped in kind of like a saran wrap so that they sweat. And then the salt content in that sweat is measured, and it's higher in individuals that have cystic fibrosis. We can now look genetically and look at some of the genes, and we have found that cystic fibrosis isn't just kind of one condition, but it's like others, it's a multitude of different permutations of the gene that can happen. And so that there can be differing levels of presentation, right? Every patient does not present exactly the same, but overall, it does have this multi-level organ involvement, and it has the chloride ion transport disruption. So again, the skin, the liver, the pancreas, the intestines, and our reproductive organs. So all of those systems are disrupted when a person has cystic fibrosis. And here we can see the difference between a normal airway and an airway of an individual with CF. It's that thick, sticky mucus. It can block the airway, it can block the alveoli. It's not an inflammation, so it's not just in one area of the lungs. It typically permeates the lungs, and this mucus builds up, and it's very difficult for them to clear. In an individual with cystic fibrosis, because there is such a disruption to the oxygenation ability, right, that intake of O2 and getting rid of CO2, we may see clubbing of the fingers or toes of those nail beds. So this is an individual that you may see clubbing on after a period of years. Also, because of the work of breathing, they become more barrel-chested. So you may see anatomical differences as well. Chest physiotherapy is a way to assist a child with cystic fibrosis to help clear secretions. And basically it relies on percussion and positioning to help the secretions by gravity and by vibration move up in the airway. So as you can see, this little child is going through their chest physiotherapy, postural drainage, and the area here that's being tapped would be a lower lobe of the lung, and by tapping, you're hoping to move those secretions up into a higher level. The child is lying with the head down, so gravity would also work to help move those secretions. Our interventions a lot of times are multifaceted, and there are a lot of interventions that need to happen at home. So cystic fibrosis and none of these conditions we've been talking about, but the first bunch of conditions we talked about were more acute. I mean, yes, we talked about the chronic otitis and some of those things, but cystic fibrosis is a chronic health condition, and management requires daily management, daily chest physiotherapy 2 or 3 times a day. And to go through every position and hit every lobe of the lungs takes about 45 minutes per treatment. So you're talking about probably 2.5 to 3 hours a day of that child and family time solely for that intervention. They also, in order to help the airway stay open, they would get bronchodilators on a daily basis, performing respiratory and supervising respiratory treatments. They also may get just a saline inhalation, and so that also helps to thin their secretions, although to a patient, they hate it. It leaves a terrible taste in your mouth. It's like inhaling salty air. And so it is not a pleasant intervention, and kids just really, I've had kids say that is their least favorite part of the whole regimen that they need to have. Administering antibiotics, because we don't want these kids to develop infections and things like that, and their pancreatic enzymes. Because the pancreas is also impacted, it doesn't release the enzymes to support digestion. So those are taken orally and with everything they eat. And teaching the child and the family about CF and its treatment. So those would be some of our nursing interventions. We're not going to watch the videos here in class, but we do have 2 videos that if you'd like to watch, it gives an overview of what it's like to have cystic fibrosis, what the day in, day out demands on the child and family are. And here we see a adolescent who is taking a respiratory treatment, right? He's got his nebulizer there and also has a vest on. And the vest is a vibrating vest. And so it takes the place of that chest physiotherapy and helps to loosen secretions so that they can cough them up and out. And then the last we're going to talk about is asthma. And as you've probably known, have you had asthma in an adult class? Reviewed kind of asthma and things a little bit, maybe, somewhere along the line? So it's a reversible obstructive airway disease, and it's characterized by increased airway responsiveness, which means that your airway becomes irritable more easily. Bronchospasms result from constriction of those smooth muscles. And the inflammation and edema of the mucous membranes that line the airways, and subsequently, because they're irritated, mucus comes in to try and calm them down and coat them, and so you get thick secretions in the airways as well. So you get increased secretions and narrowing of the airways, which is never a good combination. Symptoms indicating an emergency in asthma management is a worsening cough or wheeze of shortness of breath, difficulty breathing. Typically, our patients that have asthma have an action plan that gives their daily kind of management, what to do if they start to have an attack, and then what their third line of defense is. Using a bronchodilator, a short-acting beta agonist, is an immediate intervention. That's if you've seen an asthmatic that's got a puffer or an inhaler. If they take that, the amount of times they're prescribed to take it, wait, maybe take it again, and don't get any relief, that's a medical emergency. They need to seek help. If they have trouble walking or talking when they normally don't. And status asthmaticus is when that can't break. And so if they've taken their bronchodilator and they don't get any relief from that and they continue to just have this asthma attack, they need to go to the emergency department and will probably be admitted to an ICU because they need medical management, they need observation, we need to maintain that airway and get that inflammation down. For our children, they don't want to be kids like they are, right? They don't want to play, they don't want to do anything. They won't resume an activity if they've stopped because they're having trouble breathing and catching their breath. Our infants will be listless. You may start to see some oral cyanosis, a refusal to eat, so no interest in eating because all of their work now is just getting air in and out. gray or blue fingertips, fingernails, and things like that are not good signs. And on a child that typically has pink nail beds, good oral pink mucosa, that is a medical emergency. So we don't play around with, and kids have died from asthma, from asthmatic attacks, and so it's not to be taken lightly. We see that the medications and treatments are given and understood, and education of both the child and the family. If there have been triggers that are identified, we advise to avoid those triggers. So if a trigger is smoke, please don't smoke around your child, or stop smoking if it's the individual who's, but avoiding those triggers if there's foods, if there's fragrances, whatever the triggers might be, to avoid those, to decrease the amount of exacerbations of the asthma as possible. Recognizing early signs of an episode to get those short-acting beta agonists on board as quickly as possible, and taking preventive measures to prevent an attack. There is an exercise-induced asthma. For that, the recommendation is you take the short-acting beta agonist before you participate in athletics. That's about the only time it's prophylactic. Other than that, that short-acting is a treatment to an attack. And here is what we typically see as our asthma action plan. And it lists information for the family, who the plan is for, who the doctor is, the phone numbers of both the physician and the emergency department should they be needed, and the green zone. So everything's going well. This is just your daily management. So you're not coughing, you're not wheezing, you're not having chest tightness or shortness of breath. The child's able to do their usual activities. If they're using a peak flow meter, here's the range it should be in, because that's one way to tell how well ventilation is working. And so if the child's doing well, these are the medications to take, this is how much, and this is when to take it. So it may just be on an exacerbation, take your albuterol, 3 puffs at the onset of symptoms, and, wait 3 to 5 minutes and see, if it subsides. If not, maybe take again. Some patients, if they have multiple episodes every week of asthmatic attacks, they may be on a longer-acting corticosteroid to help decrease the inflammation over a period of time. So they may be on some baseline meds that cover them, and then use that short-acting beta agonist if there's a breakthrough event. So if it's getting worse, which means now I've got a cough, or I'm wheezing, or I have some chest tightness, I'm waking up at night. So if any of these symptoms occur, or my peak flow meter, that measure is now not as good as it should be, here's the other things I should do. So use my quick-acting beta agonist. So this tells me then what to do if I have an onset of symptoms. And then the red zone is my medic alert. So if these set of symptoms are present, this is an emergency. You need to really take and then call your doctor, right? So I'm going to take these medicines, and I'm going to call the doctor, go to the ambulance, or call an ambulance or whatever, because this is critical. So every family should have an asthma action plan, and they should know how to implement it and when to implement what steps. Make sense? I'm going to give you a break, and so we're not going to go through the case study, unfortunately, but I do want to give you a break and see if our guest lecturer is around. Any questions before we break? All right, let's come back at 10:25.
I'm in the right room. Those are my slides.
Hello. Do you by any chance know how to get the Kahoot all set up so all I have to do is press? Hi, thanks for being here. I'm Jenna.
I'm Mike.
Really nice to meet you, Mike.
I'm in the control room.
Oh, cool. Let me
Connecting
see.
you to-
Yes, sorry, and I'm sure I messed up your connection that you already had. I did not mean to. I tried not to X out of anything.
Oh, well, that would.
Perfect. I'm just not sure if I can reuse this Kahoot. Hello, I'm Jenna. Nice to meet you. Thanks for the opportunity. I'm excited to chat. It's
great.
How do I? So this was the Kahoot that I created the last time we did this talk, and I thought I could reuse it.
Right, right.
How do I get it to go? Do I do play as guest?
No,
Or does this?
there's-
Or I feel like that's.
It's your first time.
All right, folks, let's refocus. We had a respiratory lecture for the first half of class, and a little bit about med administration, too. We're going to get started. Folks here in Twin Cities and there in Rochester, let's kind of refocus our attention. Can you folks hear me okay? Yes, I will take that as a yes as we hurry to our seats. So it is my pleasure to introduce you to Dr. Jenna O'Brien, and she will do more of her introduction for herself. But she first came in and gave a lecture last semester when I was on leave and got such rave reviews from your colleagues that took this course in the fall that we invited her back to do it again. So without further ado, I give you Dr. O'Brien.
Thank you. So my name is Jenna. Oh, thank you. I got some applause here in the Twin Cities. So I'm really excited about this use of technology. Hello, Rochester people. Hi. So I actually just moved up here from Rochester. My name's Jenna O'Brien. I'm a pediatrician by training, and I worked at Mayo until this summer. And then I came back here and came to the university to do adolescent medicine fellowship. So that's where I am right now. I'm in this fellowship, and before that I was a practicing general pediatrician, and I still am. But today we're going to be talking about the ins and outs and everything in between. Specifically, we'll go through fluid and electrolyte imbalances. We're going to talk about gastrointestinal and disorders, and we're going to talk about genitourinary disorders. From my perspective, this is a lot to cover in a very short period of time. So I understand if you look through the slides, there's a lot of content in there. I'm going to try and point out the things that seem really important. And I'll point out things that are take-home messages. We're also going to do a lot of think, pair, sharing. Have you guys heard of that before? Yes, probably done this in this class before. So, and Rochester people, I see maybe some nods back there. Awesome, cool. So we're going to do a lot of breaking up and talking about cases and trying to make it really relevant for what this might look like in the kids that you guys see when you're out there in practice. So, we'll take it away. So there are 5 things that I'm hoping you'll be able to do by the end of this, and I actually think they're very lofty goals. There's big picture learning objectives. One is we're hoping that you'll be able to review common fluid and electrolyte abnormalities in pediatric patients, describe the assessment and treatment of dehydration in the pediatric patient, and you need to know what this looks like. That's actually a big take-home point. The third is to be able to outline the pathology and the clinical presentations of key pediatric gastrointestinal and GU disorders. Describe the most common medical treatments for these disorders. And then finally, design effective nursing intervention for children with GI and GU problems. So we're going to go through this, and it is a little bit rapid fire, but feel free to raise hands, ask questions, and I'll really appreciate your participation with your neighbors too when we pair together and then share what we've learned. So the game plan, everything in yellow is the first third. It's going to be fluids, electrolytes, and nutrition. Everything in blue will be the second third, that's GI, and then the final third will be GU disorders. So again, about 30 minutes for each, and I'm going to get you out of here early if I can. Okay, we'll see. I'm aiming to end 5 minutes early with all talks now. We'll see if I can do it. Okay, that being said, please ask questions. Okay, child with fluid and electrolytes and nutrition. So, first of all, I want to talk a little bit about the differences between children and adults. Children are not just tiny adults, as you guys know if you've ever interacted with one. The big picture here is with respect to the fluid breakdown, they are also different. Children have a larger extracellular fluid volume. What does that mean? It means that there's more fluid in the extracellular space, not in the cells, but outside of it. That actually leads to some issues because they can lose fluid faster. They're also not able to manage their thirst. So if you think about a 1-year-old who's thirsty, they do a bunch of different things when they're thirsty, but what they don't do is, hey, Mom, I'm thirsty, unless it's a very advanced 1-year-old. So the point is, they're not able to manage their thirst in the same way that we are, and they certainly don't go to their refrigerator and have some nice tap water come out of it because they can't. So they rely on adults to pick up on their signals of thirst, and they rely on the nurses and the teams that are there with them to pick up on those signals too. Finally, there's lots of sources of fluid loss. So there's a greater body surface area. There's higher respiratory rates, so they're breathing faster and they lose fluid that way. And they have higher metabolic rates, so their bodies are moving faster. So all of these things are different. They burn off fluid more quickly and they are at risk for dehydration. It's a big take-home point. Okay, so we're going to start with the first case. And what I'm going to ask you to do is to think about this in groups. So his name is Daniel. He's 3 months old, and he's brought to the clinic for not taking his formula, and he's crying continuously. He's had watery stools now for 2 days, and Mom can't really tell if there's urine in it because it's so watery. She doesn't really know. She's like, I think maybe he's peeing. I don't know. And he's not been drinking his formula now. So usually he would be having formula to drink at this age. That's their feeding plan, and he's not been drinking anything. So Mom's worried, and she brings him in. So first things first, what are the major concerns for Daniel? And actually, can I hear what the Rochester folks?
Yes.
Okay, cool. Let's turn their overhead mics on. So what are the major concerns for Daniel? So I want you to think about that, and then think about, hold on a sec. Ooh, there we are. What are the major concerns for Daniel? I'll have people yell out if that works for this particular one. Dehydration. What else comes? I heard dehydration from the Twin Cities room. Are there people in Rochester who think that other things might be on the table?
Yeah. Electrolyte imbalance.
Electrolyte imbalances, exactly. They kind of go hand in hand. We're going to talk about those together. Other things that might be going on with Daniel.
Weight loss.
Weight loss. Is that what I heard? Yep. Agree. So is he getting enough, especially if this was going on for a long period of time? How is he doing nutritionally? Okay, other things that could be going on. What about the causes of his diarrhea? Infection. So, is this a bad infection? Is there something else going on? Well, all of those. I agree. First and foremost, is he dehydrated? And then, is there an infection? How is he doing nutritionally? What does his weight look like? How are the electrolytes? It's kind of a secondary job. So I'm going to ask you to do in your small groups, and you can cluster with the people around you. For those at circle tables, it's nice, but for those who are on these tables or a little, just find a group of 3 or 4 people. What are the key factors in diagnosing dehydration, and what are going to be the questions that you want to ask of the parent that's there with them? So think, and then pair, and then we'll go around and share. Okay. And I'll give you guys 1 minute. 1 quick minute. It might be on the next slide. What I'm looking for is a clock, and I can get my phone out. Thank you. I was like, I just want to make sure. All right, I'm hearing some of the conversations wrapping up here in Rochester. How are you guys doing? All right, debrief time, I'm not sure. Okay, what are the key factors in diagnosing dehydration? What are the signs and symptoms we might see? We'll start in the Rochester space.
Eye of the nose, weight.
Eyes and nose and weight, totally. Other things that you might think about in the Rochester room.
Vital signs.
Vital signs, love it. What might you see?
Tachycardia.
What?
Tachycardia.
Tachycardia, so the heart rate might be fast. Agree totally. Other things you guys might say, I'm going to ask the Twin Cities room, and we'll go to the left side of the Twin Cities room at the circle tables.
Oh, they are like hypotension, maybe?
Yeah, so the blood pressure might go down, and we'll talk about that's actually a more severe sign of dehydration, more than 10% of extreme dehydration. Absolutely, blood pressure can go down. Other things you guys might see.
We just said like decrease in intake and output, skin, tartar, confusion.
Yes. Decrease intake and output, absolutely, and asking that in a way that's very patient-friendly, like how might you ask that? Not intake and output, assuming. So yeah, so how might you ask?
Like what's normal urine output for your
Yeah. Do you feel like they're making fewer wet diapers? In this case, it's a little tricky, but totally. Are you making fewer wet diapers? How many bottles have they drank? How many ounces? Most people that I see in clinic here go by ounces, depends on where you're from. Other stuff you might, and then you said confusion. I like that one a lot. Tell me about confusion. How do babies act confused? Yes.
Well, I guess we were just talking about too, like, are they acting normally or like kind of lethargic, things like that.
Agree totally. That is a big take-home point here. Your dehydrated little kid, dehydrated babies will often not act the way they normally act, and the parents are really the experts at knowing what their babies act like, because you're oftentimes maybe meeting them for the first time when you're seeing them. So listening to the family and saying they're not acting right, they're not responding normally, and in severe cases of dehydration, they may not be responding at all, or they may be super, super sleepy, but they can also be irritable, like this baby is crying all the time. So it can look a lot of different ways, and it's great to rely on the parent for that too, and say, how are they acting different? What does that look like? But then eventually, listlessness, lethargy, and we can have unconscious patients too, which is really a bad, scary sign. Okay. I think you guys got most of them. So key factors, intake, output, vital signs, and level of activity or the sensorium. I've heard that around this room. That is a theme. Signs and symptoms, fewer wet diapers than usual, which can be hard to tease out. No tears when crying. We didn't mention that one, but that actually can happen in later stages. They can stop making tears. The mouth can look really dry and sticky. They can be listless or lethargic. The skin turgor, I heard in the back, and I didn't mention it, but yes, totally. So that means like you feel the skin, and it doesn't feel like that normal smooth baby skin that's nice and full. It feels kind of sticky and thick, or is tense up a little bit. Higher respiratory rate, they can breathe faster. That's another vital sign you might see. Their fontanelle. So a 3-month-old, we have the luxury of this soft spot on the top of their head. It actually will get sunk in when you're dehydrated. So you can actually feel the soft spot before it closes. Sunken eyes, dark circles, abnormal skin color, which parents will often notice, and the temperature of the skin being cooler. Okay. There are actually ways of rating dehydration. Ooh, I didn't like the way that projected. We'll find a new one for next time. But basically, you could actually grade the level of dehydration. In an ideal situation, if you picture perfect world, they came in a week ago for a well child, you have their exact weight, you know their weight now, you can calculate the percent body weight. That almost never happens. It would be very lucky. But if you calculate the percent body weight loss, that would give you an exact percentage of dehydration. And you could replace that amount of fluid and go with that. Most of the time, you don't have a baseline body weight followed by a subsequent decline. So what you would do would be to use some of the signs and symptoms that you guys have already mentioned. So in a kid that had less than 5% dehydration, you may only see a decrease in urine output, and maybe that's it. But as you get more severely dehydrated, the moderate dehydration phase, you'll see a slight increase in heart rate. And then really with the severe dehydration, where you've lost more than 10% of your body weight, will you start to see the blood pressure. So one thing that I highlight with everyone I work with when I'm on service in the hospital or with a baby is that blood pressure thing, that is an end stage sign. So that is a scary sign, but you're going to pick up on these other things if you're paying attention earlier. So it's a really key thing for you guys to be tuned into some of these other signs that we've talked about before they start crumping, to be quite frank, and before they start really, really getting sick. Okay. There's also lots of different types of dehydration. We're not going to spend a ton of time with this, but one way that we classify dehydration is by level of sodium, okay, because the sodium levels are impacted by the amount of fluid in the body. So isonatremic dehydration is when the sodium concentration is actually identical to what it would have been beforehand. It's in the normal range. you lose the body fluids that contain about the same amount of sodium in the blood. It's equal. That's really common. Over time, you can get hypernatremic dehydration. That's when there's too high sodium. And then the sodium is above that of normal fluids. And hypotonic, so hyponatremic or hypotonic dehydration is when the sodium concentration is below that of normal fluids. And this all relates to the way that the person got dehydrated. We won't go into a lot of detail with this, but it's important to know what the sodium is when you're managing dehydration because it will impact the type of fluid. It might impact the type of fluids you give. It might impact how quickly you give those fluids, and it might change what you're managing for. And when we rapidly change sodium, it can lead to big issues. So it's something we kind of change slow and steady, and we monitor closely. Okay, we're going to continue with Daniel's case. We're going to do another think, pair, share. So 3 months old, he's brought into, just a reminder, brought into the clinic because he's not taking formula. He's crying continuously. Now mom gives you more of that data. So he's, like we've talked about a little bit already, watery stools for 2 days. They can't tell if there's urine in it. He doesn't want to eat his formula. He's crying all the time. Mom can't get him to stop. We ask those questions about confusion. Mom says, this is very different. He won't stop crying. I can't even make him laugh or smile like usual. He has no tears when he cries, and he's had a fever. She doesn't have a thermometer at home to take a temperature, but mom says he just feels really warm. Objectively, you collect some more data because you're looking at him and you're assessing all the things we just talked about. He's listless, he's lethargic, he's pale, he doesn't seem to be reacting much, he's really irritable. Sunken fontanelle, so you guys notice that soft spot. His stool is really watery with green flecks and brown, but no blood. And his temperature is 102.2 degrees Fahrenheit. So he is a temp. His pulse is 152 beats per minute. How does that feel for people? A little on the high side. It probably, for those of you who've worked on adult floors, it probably feels kind of high for that reason. This is not terribly abnormal for a baby, but it's a little bit on the higher side. Remember, most newborns will have a heart rate in the 140 to 160 range. So babies can have higher heart rates, but I would agree this is on the higher side for a kid this age. And the respiratory rate of 65 breaths a minute, so also a little on the high side. So in your small groups, what's the main concern for this infant? What treatments do we consider? What lab work would you expect to be done for the child? What are you anticipating that the labs that are going to be done? And what can the mom do at home in the future to help treat this at home? So that's kind of a big bucket, so we'll give you about a minute and a half, which is also a small period of time. So think, pair, share. Let me know how we're doing on time first. I'm going to keep looking at the clock, but the nice thing about think, pair, share is that it gives me a moment to be like, okay, how am I doing? I feel like I spent a lot of time. Yeah. Okay.
When I was in New Jersey.
All these other things that are important, but the thing that you get the flu, you get a flu, you get any of these things, you get this information people also use that too. So,
It's like, oh, we're running scores, so, I mean,
yeah. And we can do supportive care. I think with this case in particular, when I think about cases like this, there's some supportive care we could do early on, and that's what I think is a big deal. Right. About 30 more seconds. I see conversations wrapping up here, so that's good. All right. Things are quieting down. That's good. Okay, we won't do 30 more seconds. Unless, Rochester, are we good?
Yeah.
Okay, cool. So I'm going to start on the right side of this room because I haven't asked the right side of this room anything yet. Sorry to put people on the spot over here. Let's do questions 1 and 2. What are the primary concerns for this infant, and what treatment should we consider? And you can add in anything else you want to also.
Primary concern would be dehydration or electrolyte imbalance.
Okay, dehydration or electrolyte imbalance for the Rochester. Okay. Treatments, and why don't we do treatments and labs together than you might anticipate might happen for this kid.
Treatments would be fluid replacement, and maybe a hyper or hypotonic solution depending on the lab results, and probably a CBC with the electrolyte counts.
I like all of that. So I think, let me make sure I got all of it. Fluid replacement, so we're saying, okay, we're going to have to check electrolytes. We need to know what kind of dehydration this is, especially if we're worried that they're sick. And then you mentioned a CBC, so a complete blood count. I'm guessing you're thinking about, like, is there an infection going on of some kind? What could be going on? Is there other stuff going on? Agree totally. Other things that you think might happen, we'll go with the middle of the room. Middle left of the room here, and then we'll go to Rochester. Labs or medications?
Stool sample.
Okay, someone might get a stool sample. I actually agree. I think in this case, someone might grab a stool sample, and I think that would be reasonable. If there were blood in the stool, even more so, which might be more of a sign of bacterial illness, bacterial diarrhea. But yeah, thinking about what is actually causing this diarrhea. Agree. So there's the how do we manage it, and the what. How do we manage the issue right now, and how do we get at the underlying cause? Agree. Other things.
IV fluid replacement.
IV fluid replacement. Agree. Rochester team over there. What can the mom do at home to help treat this condition in the future?
Pedialyte.
Pedialyte. I love that. And I don't have like any stock in Pedialyte, but I certainly recommend a lot of Pedialyte to people because oral rehydration solution early on in a diarrheal illness. Yes, some kids will still get sick. Yes, sometimes there will still be a lot of diarrhea. But if you get the call at 2 hours into this illness, you might start rehydrating with Pedialyte early on, and that might actually help curb some of the dehydration symptoms that can make kids really sick. And the problem is the more dehydrated you get, the more irritable you get, the harder it is to even keep drinking fluids and things. So it really is a cycle. All right, cool. You guys, I think, hit there's a little bit more. One more thing that we didn't hit. So with babies, and this is just a point to highlight just more generally, with babies, you guys mentioned this infectious workup piece. I want to highlight that this is actually something, yes, totally, this is something that we need to be thinking about a lot. So when a baby comes in with an infection, we take it really, really seriously. And a baby who looks ill, especially a 3-month-old or a 2-month-old, might actually get a full infectious workup with blood cultures that would need a blood draw, with a urine culture, thinking about a UTI, and might get a stool sample like we talked about. We heard about a CBC, agree totally. They actually might even get a lumbar puncture, like a spinal tap, if they're not acting right. And the reason why is that we take fevers in babies really seriously, and we take abnormal or like altered mental status and altered sensorium really seriously in babies. So just so you're aware, if you see a baby come in with some of this stuff, people are going to be taking that really seriously, and you're going to be seeing that. You'll be seeing a lot of people in that room real quick. Okay. Future prevention, you mentioned Pedialyte, I agree. Once you identify that you're losing a lot of fluid, start to rehydrate with electrolyte solution. Yes, it's better than juice. Yes, ideally better than water, but if they only want juice or water with younger kids, that's okay too. We just try and dilute it, and the electrolytes really are the key part of this, and that's why Pedialyte works well. If the vomiting or diarrhea continues for more than 24 hours, let's just say we got that call at the 2-hour mark, I usually have people come in, especially with younger babies. Okay, calculating pediatric fluid needs. And this, I think, is one of the a little bit more complex parts here, and I'm going to try and explain it in a few different ways for everyone's brains who process this differently. I think if you ask different providers in this room, we all probably calculate it a little differently too.
And that's good, because we just went through it.
So that I won't harp on it. You guys already know about this. This is good.
No, but I was going to say, if you've got a different way of explaining it, I think that's not a bad way to go about it.
Yeah, so basically the bottom line here, I think the big picture is there is a basic amount of fluid that people need every single day in order to continue and maintain. We call that the maintenance, right? And then there is rehydration. So then there is, I'm already behind on fluids, I need to catch up with them and rehydrate, right? So who here has heard of something called a bolus? Like they need a bolus, right? That is by definition a rehydration. So they're dehydrated, we're going to give them a bolus to fill up their intravascular volume and get them okay, especially if they're having low blood pressures and things like that. You'll see that a lot. So I think of it in 2 buckets. For maintenance, which people need at baseline, for this kid who's not drinking, he needs at least his maintenance, right? But he may also need rehydration on top of it with something like a bolus or with even a higher level of maintenance fluids. So So the way that I think about this, and you guys have probably just heard about this, so walk me, if you guys are like, I already know, we're good, is I think about the hourly rate, about what they would need for maintenance, and then I think about plus the deficit. Like how far are they behind? Does that make sense? So the way to calculate the maintenance is this 4-2-1 business. Is that what you guys just went over?
No.
Nope, okay.
We did 10-50.
10-50-20. So again, this is like, everyone has different ways of calculating it, and you'll get to the same number. It's all about how you think. 10-50-20 is the over a 24-hour period. What I found myself in the hospital frequently was I was looking for an hourly rate. And you can do the full day period and then divide by 24. That's one way to do it. You can also do this 4-2-1, which I have here. I don't know if you guys can see. Can you see my arrow? Yes. The 4-2-1, this is what I use, but either way will get you to the exact same number. You can try it both ways. Essentially, for the first 10 I think of it like a whole person. The first 10 kilograms, let's say that's to the knees, that's 4 mils per kilo per hour. So if a baby is 10 kilograms, that would be 40 milliliters per hour, or 40 milliliters per hour would be their baseline rate. If they were, say, 20 kilograms, the second 10 kilos, so if you think about starts at the knees and then going up the second 10 kilos, that gets 2 mils per kilo per hour. You can do the same thing, 100 with the middle formula too. And then if they're anything above the 20 kilos, they get 1 mil per kilo per hour. Again, if you calculate it the way that you guys learned originally or the way that I'm explaining now, using any of these formulas, you will get the same thing. The bottom line is this is the maintenance rate. Does that make sense? And we're going to do a practice question just to put this into action. And you can do it in whatever way works for your brain that makes sense. But I have the formula in 3 different ways here. Then with rehydration, and this is a bottom line with how do we rehydrate this kid? For mild to moderate dehydration, we actually start with oral rehydration therapy. So you can actually use Pedialyte, a really nice rehydration solution like that, or a similar generic, at 50 to 100 mils per kilo over a 1 to 2 hour period. So for a 10 kilo kid, you're looking at about a liter in a couple hours. That's hard. I can barely drink a liter in a couple hours, especially if I'm talking like this. But the point is, it's hard to do, but this is actually where we start. And the way that I've seen people do it, I've seen them use syringes of 5 milliliters every couple of minutes, and we do that with babies in the hospital. We've seen them put it in their favorite cup for older kids, and we just push it. Once you get into the moderate to moderate severe range, then we're talking about we need to rehydrate in a different way. And with that, we'll use a bolus, and usually it's 20 milliliters per kilogram of a bolus. And sometimes we actually run a higher hourly rate too. The one big thing here in terms of the fluids we use, you will almost never see somebody bolus a fluid that contains sugar. So you will almost always see a bolus with saline and lactated ringers, which are non-sugar containing solutions. And you will not see them do it with weird saline. Usually you will almost never see them bolus with a weird saline containing. It'll almost always be this normal saline solution. And I want to highlight that because I've had it happen and it was a major medical error where somebody bolused a D5 half normal saline, and that is not something we do. It can lead to significant issues. So when we're rehydrating, we use normal saline or lactated ringers almost always. Does that make sense? And then we manage some of the sodium stuff too. The bottom line here is they need fluid. Is that consistent with what we just heard in the previous lecture? I want to make sure if that was just talked about.
Yeah, we didn't talk about
the type.
Rehydration.
Yes, and basically that's how we rehydrate. So we're going to do Jimmy. He's a 3-year-old, 14 kilo boy. He has had diarrhea and vomiting for 2 days. He is getting IV fluids, D5 half normal saline. They're running at 70 milliliters per hour. He's not able to drink any liquids on his own. What are his daily fluid requirements? Is 70 mils per hour right? Is that okay, or is that something that would raise a flag? And what should the RN be monitoring after adjusting the IV fluid rate, and why? So you guys can discuss and think, pair, share. This is meant to be an application of what we just learned. questions, feel free to ask each other or raise your hand and I'll come over. Sorry, Rochester crew. If there's questions, feel free to raise your hand in Rochester. And then on the adult side, administration is one of the biggest, most simple things for anyone who's ever working with a child. And then just recently on an adult board, they're like, what's the dose? It depends on the class. And the vital signs thing. I think that's the other big difference. 156 now, 156.
Yeah, but and it's also just the challenge of listening.
Where were you? Oh, cool. Yeah, I'm originally from East Coast. Okay, that's why I'm a fast talker.
I was about to Brunswick.
Oh, sweet. That's great. Yeah, they're great hospital. Yeah, they had a bunch of times mentioned that. And I just met a couple of the UFDA folks today.
Oh, okay. Yeah.
Sarah. Yeah, all right, how are we doing, guys? Do people have thoughts? Okay, we'll start with the Rochester crew because I see some really good conversation going on there. What are Jimmy's daily fluid requirements, and is 70 mils per hour correct? Or does it feel right or wrong?
His fluid requirements are 1,200 milliliters over 24 hours, which means that 70 milliliters per hour is too fast. It should be at about 50 milliliters per hour.
Perfect. So if he were completely well hydrated when he came in, you would go with about 50 mils per hour, 48 mils per hour based on that daily requirement. I agree, and I actually encourage you guys, if you do get an order for a fluid that feels too high, please say something because we're not all great at math and sometimes errors happen, especially in the middle of the night or during the day. Agree totally. If he were dehydrated, would it be okay to give 70? Yeah, it depends. So if he gets a bolus in the ER and he's looking better, yes, maybe would want to be lower, but if he were, so it kind of depends. So if he were like still on the dry side or maybe got one bolus but still looking not great, you might run a higher rate. So it's kind of an it depends question totally. I agree, 48 to 50 mils per hour depending on the method you use, that 2 cc's is totally fine to adjust. Unless you're in the NICU, then 2 cc's is not okay to adjust the neonatal ICU, not the neurologic ICU. But the bottom line is 70 mils per hour feels a little bit high. But if they were super dehydrated, it might be okay. And what is the RN monitoring? I'm going to ask the left side of the room. What should the RN be monitoring as you're making these fluid adjustments? What are the things to be looking for? Left side.
Reassess like the fluid and electrolyte.
Yeah, so looking at his fluid status, looking at those same symptoms that you might see, looking at the eyes and O's, and if they're checking electrolytes on a daily basis or some period of time, making sure that they look okay and they're in the normal ranges. Other thoughts? Weight, yes, and that actually is something we monitor frequently in kids and babies because it's a nice surrogate that changes as you gain and lose weight. And also, I would argue the IV site. Occasionally we have an IV infiltrate, and what'll happen if this kid is getting IV fluid, you want to notice that beforehand so it doesn't cause a large amount of swelling. And that happens. It's no one's fault. It just happens, especially in babies and younger kids. And you guys got all of this. Okay, cool.
Would you listen to lung sounds too? Is that like a concern like it is in older people?
That is a great question. And you're thinking about congestive heart failure or fluid overload and some lung findings there? Is that where you're going?
Yeah.
Yes. So a little less likely to happen in babies than with the elderly, but absolutely could, especially in younger babies that come in. We occasionally will hear some rails in the lungs too. It's a good idea to listen to babies' lungs and heart anyway to be on a periodic basis. But yes, I think it's a reasonable thing to do. It's a little less often seen, thankfully, because their hearts are usually functioning very well if they're an otherwise healthy kid, depending. But yes, I would say if you're hearing rails in the lungs, you'd be saying, could this be something that we did? Could it be the fluid that we gave? And that happens, unfortunately. Yeah, so if you fluid overload that, and we do have this happen, especially in younger kids, you'll see edema. Yeah, you might. With functioning kidneys and functioning hearts, it's a little less often than in adults that we overload, but it still can happen, especially in kids that are sicker. Totally. Other thoughts? I think you guys are great. So the causes of diarrhea, I wanted to run through, and this kind of overlaps between GI and FEN, but causes of diarrhea, there are basically some big red flags that make me worried about scary causes of diarrhea, and I've listed them in red at the bottom. Blood in diarrhea can happen for lots of reasons, but oftentimes is a sign of any of the things in red here: bacterial infection, intestinal obstruction, which we'll talk about in the GI part, also known, and one common cause is intussusception, which we'll talk about, malabsorption, and inflammatory bowel disease. So blood, fever, poor growth, severe belly pain, and long protracted symptoms, I would add to this list actually, would all be signs of scary causes of diarrhea that are on this list. Does that make sense? But there's lots of diarrhea that happens for lots of different reasons in younger kids, and most of it is benign, but if you're seeing these red things on here, these red flags, I would ask them to be seen sooner. Okay, what would you tell Jimmy's mom on day one of illness? And this can be a 5-second turn to a partner. Practice counseling the parent. Okay? Okay, they're talking. Okay, I know that was super brief, like a 30 seconds. What are the things that you would say to make sure you tell mom, the mom who calls in, and I'm sorry, it could be dad, the parent who calls in and says, my kid has diarrhea, my 3-year-old, or I forget how old he is, 3 I think we said, has diarrhea. What are the things you're telling mom or dad or whoever calls? I'll have you guys yell it out. The warning signs. Okay, these are the things that could happen. So all of those symptoms we talked about. If they're not making wet diapers, if they're not acting right, if this keeps on going, come on back. If there's blood, if there's severe belly pain. Okay, so the warning signs to look out for. What else are you going to tell them? Don't all jump at once. Rochester crew? I heard something?
Push the fluids and maybe get like Pedialyte or something.
Totally. Push fluids, and ideally, if you have Pedialyte would be great. Cool. I like those things. Pedialyte, continue, if they're nursing, continue breastfeeding. They do not need to stop breastfeeding if they're nursing. This is a 3-year-old, but for the infant or younger, and some 3-year-old parents are still breastfeeding too. That's totally fine and safe. I would also add, avoid juice, sugary, and spicy foods. So juice actually has lots of sugar in it and actually can worsen diarrhea. So ideally, that's why we like Pedialyte a little more than, say, Gatorade or juice. And good hand washing. That way no one else in the family gets sick. And then the other big thing is with somebody who's wearing a diaper or somebody who's not fully potty trained, diarrhea can make a big mess and cause a bad diaper rash. That might be another thing you might anticipate. And then totally what was brought up here, when to call. This idea of what are the bad things to be looking for, because that's really important for a parent to be watching. Okay. I'm going to mention one more thing in this fluid and electrolyte, and this is a quick run through of a very complex topic that we're not going to go into in detail. But I want to mention that there is one other element of this electrolyte and fluid piece, which is the acid-base balance. Okay? So in addition to having imbalances of electrolytes, you can also have imbalances of acid and base. So the pH of the blood can change. For those of you who've taken some chemistry and biochemistry courses, or you guys have probably, for those who've been in those courses so far, this is a complex process and there are some buffers in the blood that kind of monitor this. But I wanted to give some examples of acid-base imbalances that occur in babies or in children. So you can lose a lot of acid by vomiting, and that can lead to an alkalosis or a high pH issue. You can lose a lot of base with diarrhea, and that can lead to an acidosis. You can ingest something, so children will sometimes ingest something that is itself an acid or a base. That can mess things up. And those are all considered in the metabolic range, like type of acid or acidosis or alkalosis. Some other metabolic, the body can produce too many acids of their own. So in diabetes, and you'll get this in the endocrine side, your body produces a lot of ketones because it's in kind of a starvation state. Those are acids, and that can actually lead to an acidosis. It's another type of imbalance. Respiratory. So the way and how fast you breathe determines how quickly or slowly you're blowing off carbon dioxide, which itself is an acid. So when you are hyperventilating, you lose a lot of acid, and you can actually get a respiratory alkalosis from hyperventilation. So kids that are breathing really fast can have problems. In fact, in diabetic ketoacidosis, one way that the body compensates for that is by breathing really fast. And if you see little kids presenting or adolescents presenting with new onset diabetes, you'll sometimes notice them doing this fast breathing to blow off some of that acid. And then finally, you can have hypoventilation for and develop excess acid from not breathing fast enough. So you'll see this, and I think the classic example of this is either a young person or an older person in the hospital who, for whatever reason, is getting a lot of opioids, so their respiratory response is slower, and they can actually accumulate carbon dioxide and accumulate acid in the blood, and they get a respiratory acidosis. That's another type of imbalance you guys may see in the hospitals, and it's a little bit, we're not going to talk about how to manage that today, but there's also it dramatically impacts the way that we think about the fluids we're picking and things too. Okay. And the bottom line with that is to correct the underlying issue. So if you correct the underlying issue, or you manage the ingestion, or you manage the diabetes, the acid and base balance gets better. Does that make sense? And the other thing to mention about this is that the acid and base balance can affect the way that the electrolytes are in the blood. So these are all linked to each other. So if you're seeing abnormalities in potassium, or if you're seeing abnormalities, that way they can be impacted by this acid-base balance. So it's all connected to each other, but we won't go into too much detail on that today. Okay, we're going to move on to the blue section, which is gastrointestinal disorders, which is perfect. We'll have about 20-25 minutes for that. The child with GI alterations. Everyone okay? We're moving on. Okay. Age-related differences in the GI system. So the stomach is positioned a little bit differently in kids than with adults. They have a small stomach that is positioned horizontally that slowly progresses as people age into a more normal slanted position. There's a shorter large intestine. The peristaltic waves through the GI tract are faster. And there's an immature liver, which is also part of the GI system, so they might not process the same medicines the same way that we do or as quickly as we do. So lots of differences. With kids, we oftentimes will talk about embryologic disorders, so disorders that occur, structural disorders that occur starting when the embryo is developing. So there's that kind of bucket of disorders, essentially. And the GI system forms within the first 4 weeks of embryologic development. So we're talking about literally the 4 weeks after conception that this is happening. So examples of this would be like a cleft lip or palate, and we'll talk about what that looks like. Esophageal atresia, so the esophagus may not develop normally, or may be connected in some way with the trachea, so tracheoesophageal fistula. Upper GI hernias, so you can have a couple different types. You can have hernias that go through the diaphragm, where the GI system where the stomach kind of comes up through the diaphragm. You can also have the other parts of the GI system come into the diaphragm, or come through the diaphragm or into the chest. You can imagine that causes problems. I'll show you some pictures. I think a picture is worth 1,000 words in this talk, so we'll talk about what that looks like. Gastroschisis and omphalocele and umbilical hernia, these are all different belly button issues where the GI tract comes through it to some degree through the belly button. And then we'll talk about imperforate anus. So again, the anus does not open and it actually is closed. And that's actually something that we've detected. And actually I've had 3 different nurses detected in this case. They've all been detected by nurses, the ones that I've seen when I was in residency, are people who went to go look at the baby's butt and said, where is the baby's butt? And so basically we'll show you some pictures and what that looks like. But the bottom line is you guys are going to be front line with these kids and you will be seeing these along the way. So we'll talk about what this looks like. Cleft lip and palate. So you guys have probably seen pictures of these around. There's a lot of really great organizations that do work in the cleft lip and palate agency or in the cleft lip and palate world. You can have cleft lip, you can have cleft palate, you can have both together, you can have them on one side, you can have them on both sides. There's lots of different ways that they can look, and that's what this picture is looking to depict. These kids do really, really, really well. Usually they are isolated things, that it's only this part of the body that is affected. Occasionally it can be associated with the syndrome, with other genetic stuff going on. These kids get surgery and they heal well when they are able to be repaired early, and they work closely with a multidisciplinary team, including PTs and OTs as well, to help them recover and heal. And orthodontics and all of this piece too. But I'll show you some pictures and we'll go. Tracheoesophageal fistula. So this is actually one that isn't talked about much, I think, in the media and places. But what this is it's an abnormality in the way the esophagus and the trachea form and close together. So, and this is all an embryologic issue. So you can see, I'm going to point with my arrow on here, the different types. 87% of these are this type here, this first type. And what you can see here is the esophagus comes down and it ends in a blind pouch. So you can imagine what these kids might look like. They try and eat, and where does the food go? Into a blind pouch, and then they spit it right back up. So it can cause some issues that way. And again, these can be repaired, but you need to detect them. So if you're seeing lots of babies are spitty, but if it's a spitty baby who's really having trouble, we go down this road. And this needs to be repaired quickly, essentially. You can also see that the bottom part of the GI system is connected to the trachea. There are other variations of this, and the one that I'll point out here is this middle one. And you can imagine with this one, the food that he's being fed is going directly into the trachea and directly into the lungs. You can imagine that would cause lots of different issues. The way that I've seen this diagnosed, in addition to frequent vomiting and frequent coughing and issues like that with any of these, is somebody goes to place an NG tube because a kid's not feeding well, and they take an x-ray to check where the nasogastric tube is, and instead of being in the stomach, it is curled up in the throat. And you can see that on x-ray because instead of going down where it's supposed to go, it's curled up. And you can imagine that that could cause issues if we don't diagnose it. So again, things to be on your radar that this is occurring. Okay. Congenital diaphragmatic hernia, and I briefly mentioned this, but basically what's happening here is that there's an intestine protruding through a hole in the diaphragm. You might imagine with this one, in this x-ray, what do you guys see? Hold on. This chest x-ray. I don't know. I know you guys haven't done a ton of that for me yet, but so what I'm going to show on this side, where's my arrow? Here we are, arrow. Okay, so on this side, that's normal lung tissue. This middle part is the heart. And what's happened here, this bubbly stuff over here, that is intestine in the chest. The more you feed this kid, or the more you pump air into their stomach by helping them breathe and all of this, the more their heart and lung will compress on the other side. So again, diagnosing this early, and we occasionally will diagnose these prenatally. Usually we diagnose them prenatally now. The earlier we diagnose this, the better it is, because we're able to then decompress the belly and allow them to have a repair. But again, if you were listening to this kid's chest, like we kind of mentioned, you actually may hear bowel sounds in the chest wall. So if you're listening and you're like, I don't hear any breath sounds, but I hear gurgling that sounds like stomach, this is something that needs to be on your radar. Okay. Motility disorder. So that's kind of a quick survey of embryologic issues. Now we'll go to motility. So this is an issue with the way things are moving. These are among the most common that we see in kids. Gastroesophageal reflux disease, constipation and encopresis, which means stool leakage around constipation. Recurrent belly pain, we see all the time, and irritable bowel syndrome, we see all of the time. These are issues with the way the gut is moving in some way. And they can happen for other reasons too, but that's kind of a bucket and a way to lump them in. I want to talk briefly about reflux, and you guys may have heard a lot of this before. The biggest things with reflux that we do are changing in positioning and lifestyle stuff, so working with diet and things like that. This relates to that abnormal position, that normal positioning in the baby of things being horizontal and the lower esophageal sphincter, so that lower part of the esophagus being really loose. Stuff comes up, the milk comes up and is more likely to just come out. Almost all babies reflux to some extent. If anyone has ever taken care of a baby, you almost definitely have been covered in spit up before, and that is okay and normal. When it becomes a problem where the kid can't feed or can't gain weight or can't grow or is miserable, that's when we start to think about doing some of this stuff. Occasionally we will try medications, anti-reflux medicines. Those just suppress acid. They do not get rid of the reflux. They just suppress the acid so they can help make kids a little more comfortable. And it's actually not first-line treatment now to start them. That's things like Zantac or omeprazole. We occasionally do it in cases when things are pretty severe. Surgery occasionally is done for reflux too. That's extremely rare and only in the most severe cases, but I wanted you guys just to be aware that there are people who are doing this out there. Constipation. So there's lots of issues with constipation. It is probably one of the most frequent causes of abdominal pain in children and adults. And really it probably relates to a few different things. One is our diet. One is drinking inadequate fluids. And another is the way that we position ourselves on the toilet. And you can see a picture here. Many children in particular sit on the toilet with their feet dangling, and that just does not make it easy to relax and have a bowel movement. So we think that this frequency of constipation may relate to lots of different things: a lack of fiber, fewer fruits and vegetables, fluids, and the way that we go to the bathroom. The biggest things we do initially for this are diet. Changing the diet around, increasing fiber, increasing fluids, helping with positioning, reminding people to put a stool under the table. This is like basic, but yeah, under the toilet rather. And then medications, we occasionally use things like Miralax. It's probably the most common one you'll see in other things too. What encopresis is when you have such severe constipation, that's the picture above, that fluid actually leaks around the poop, and you can actually have 5, 6, 8, 10-year-olds who are having leakage of stools into their underwear. And you can imagine this is a big issue socially for kids. And even though parents will come in and say this is diarrhea and they're leaking diarrhea, it actually is constipation, and it's a common thing that we see. So you may see this around. We'll move on to inflammatory and infectious disorders. Again, this is a brief survey of them so you're familiar with them, but not a dive deep. One is appendicitis, which many people have heard of. It's an infection of the appendix, and we'll talk a little more about it. Inflammatory bowel disease is a chronic disorder that's an autoimmune disorder that frequently presents in adolescents. Two types of them are ulcerative colitis and Crohn's disease. Ulcerative colitis involves the colon. Crohn's disease is a full GI system issue, and they're both autoimmune. And you can have stomach ulcers, which is another inflammatory thing, oftentimes related to infection with H. pylori. And you can have infectious gastroenteritis, so infectious causes of diarrhea, which are some of the ones we talked about before, like bacterial and viral illnesses and parasites. That's a big, brief overview, but we're going to do a case now to break it up because I've been talking for a while. So a 10-year-old boy with belly pain. The pain started off all over his entire belly and then moved to the right lower quadrant. He actually drew it on there for you. He wrote 2, 1, 3, and he wrote on his belly where it is. He said the pain started off all over and then moved to this right area, this place labeled 1 and 2. 1 and 3 rather. He says he's had fever, he's been queasy, he vomited once, he has decreased appetite, and his stools, he says, are, quote, normal. Which everyone says their stools are normal when you ask, but he says they are normal. Okay, so the question for this is, what do you think is going on with Michael, and what workup and cares are you anticipating he's going to need? I think I put him in we'll put him in the primary care office. Okay, so pair together, and I'll give you guys a minute and a half. Okay. The one that I think is like the eyes, like, so big.
Yes.
Oh, I'm trying to highlight the ones that I think are like most And if there's things that you think could be different and that I need to be highlighting more, will you let me know? Absolutely. And if there's things that I would love to see the feedback on this, but if there's things that come back and they're like, this was really overwhelming or didn't make sense, I would agree.
This, I had respiratory opened up.
Okay.
I realized just for their.
I didn't know which lectures or which chapters. Oh, okay.
I mean, they should have just,
you know. Back in school now, so I'm back in this like current like reading cycle, like trying to. I went back to do an MPH. So I was public school now. But I've been back in this like. I'm trying to figure out exactly where to find everything. And I have like a schedule like this for all my classes, but I forgot how many of them.
It's weird what makes sense. You know, we all think different.
Yes.
Yeah, I often have discussions with our. You should design it for you like that. That's not the way I would do it.
That's not where I look. And everyone looks at something like some people look in campus. So, you know, like it's hard. And then you want to have it in each of the spots, and you're also like, we want it to all be unified. All right, about 20 more seconds. Make sure you're thinking about the workup and cares that are needed. Okay, so we'll start with the right side of my right side of the room here. What do you think is going on with Michael, and what workup and cares are you thinking he's going to need when he's in the hospital or when he is in the office? We can do this whole area so it's not just pressure on that one table, sorry. I assume you talked about it. Somebody. All right, somebody who is wearing a University of Minnesota outfit. Hold on, there's less than I was expecting, sorry. Somebody.
Appendicitis.
Appendicitis, okay, and what workup and cares are you anticipating they'll need? Somebody who's wearing pink. Or purple. Oh, there's a bunch of pink and purple, okay, good. Yes.
Probably like labs, like CBC.
Yes, labs, totally. CBC, agreed.
A thorough abdominal assessment.
Yes, a good abdominal exam. Where exactly is the tenderness? That idea of point tenderness is really critical for an Abby, if this is what this is. Rochester crew, other things to add? I couldn't hear. What?
Nothing to add.
Nothing to add. Okay, cool. Yeah, so I agree. I think this is appendicitis. I agree. Well, we'll talk. It is probably appendicitis. Other things to be considering that are on the differential, because whenever we think about a person coming in, we think about more than just the most likely. We say, this is probably most likely, but what are the other things we need to be thinking about? Gastroenteritis. So he could have a stomach bug. Constipation, inflammatory bowel disease, and GU pathology, which we'll talk about. But for young men, you can have testicular torsion. You can have other issues that are going on, which is why an abdominal exam and also a testicular exam would be really important in this case. And pneumonia can present with abdominal pain, but usually upper, not lower abdominal pain. Cares. So the other thing I would mention, you mentioned the lab, CBC and electrolytes, agree. They probably would do imaging in this case, because that's how you would diagnose appendicitis. In younger kids, we oftentimes will start with ultrasounds. With older kids, especially bigger kids, it's a little harder to see on ultrasound. We still try and start with ultrasound because there's no radiation with it. But if we can't see it that way, they'll sometimes go to a CT, and that's oftentimes the first line testing in adult care. The other thing you may see happen here is you may see electrolytes being grabbed, and you may see a surgery consult happen really quickly. So if there's a really high suspicion for appendicitis, like we kind of mentioned in this room, you're probably going to see a surgeon pretty quickly in this too. In complicated cases, you may get antibiotics, and actually, the traditional teaching was always that people with appendicitis were going to need surgery, but now there's actually some people that are talking about treating with antibiotics as a first line. So there's some studies coming out about that. Fevers, think infection, and appendicitis is in fact an infection of the tiny little appendix in that right lower quadrant. Okay, so bottom line here, fevers, think about infection. Okay. Oh, and I'll point out, his low appetite and nausea are characteristic of appendicitis. So not only do you see usually a fever, nausea, and low appetite, we call it anorexia as low appetite, we also will see the abdominal pain. So that constellation of symptoms should raise your red flag. Okay, let's just say this is our 10-year-old Michael again, but now he's been experiencing the same symptoms of belly pain and right lower pain for 3 months. And he's had bloody poop. And you look at his growth curve, because you're all over this weight and growth thing like we just talked about, and he's had a 15-pound weight loss. Then what's the differential, and what are we thinking about? And this is a bonus question. I see some words being spoken, and I think they're correct, so I just want to go with that. Well, there's a lot of things it could be. There's no correct or incorrect, but yeah. What else could it be? Yes? Yeah, it could be ulcerative colitis or Crohn's disease, actually. Could both look very much like this, and that's another highlight of, if you're seeing blood and chronic symptoms, we need to be thinking about scarier things or longer-term things. Inflammatory bowel disease is one. Other things you might think about? I agree. Crohn's or ulcerative colitis, totally. Okay, cool. And Crohn's disease is an inflammatory disease of the bowel and ulcerative of the GI system. And the ileum is actually the ileum and the cecum are common areas that are affected. You can see here the ileum is just the tail end before we go into the large intestine. That's a common area for Crohn's disease. But ulcerative colitis also presents just like this too. And you would not know the difference until you were to do a scope or imaging. Okay. With something important here, and I've been trying to highlight everything important in red. When persistent symptoms of weight loss are happening, think about a chronic process. Weight loss in kids is almost never normal. Weight loss in adolescents is almost never normal. Look and see about what else could be going on. Okay. Obstructive disorders. So these are disorders of blockage. So they are disorders where things get in the way of things moving forward. In young babies, you can see something called hypertrophic pyloric stenosis. I think I'm going to show you a picture of that one. You can see Hirschsprung's disease, you can see intussusception, and you can see volvulus. And I think I walked through each of these. I want to make sure. Yes. Pyloric stenosis. So what this is the pylorus is the bottom part of the stomach. The muscle around the bottom part of the stomach gets really big or hypertrophic, and it blocks the exit to the stomach. These kids look like happy spitters. They eat, and then they spit up almost immediately after. The spit up is forceful. So frequently parents describe their kids' vomits or spit up as projectile. And that means something to providers, and for those of us who are in healthcare, we're going to be, like, when people say projectile, what does that exactly mean? In pyloric stenosis, it means hitting the ceiling. And it usually is in infants. It's actually very impressive and very forceful. So forceful vomiting and happy spitter and not being able to grow at around 2 weeks of life, that's going to be pyloric stenosis. It's actually really cool the way that they manage this. What this is showing you, the way they manage this, they actually will use a balloon, or they'll actually do a cut, and they'll actually break the muscle open, and it relaxes, and it gets better. So they actually repair this surgically. Okay. Infant, I'm just debating about skipping this case. So 2.5-week-old who has just received surgical repair of pyloric stenosis is being admitted to the pediatric surgical unit. I'm going to walk through this one verbally so that we can move on, because I want to make sure we have enough time for GU. And I still get you out early. So, describing the symptoms of pyloric stenosis, I just kind of move forward. How would that inform your nursing assessment and care? I'm going to have people kind of yell this one out. If you're diagnosing someone with pyloric stenosis, what would you expect them to have in the hospital? They're coming in, they've been spitting up for 2 weeks straight, and they're an infant, they've lost weight.
Parental nutrition?
Yeah, so they're going to need nutrition. We probably can go to TPN initially, but it's a really good thought if this were chronic, and we do that with some babies that have obstruction. In this, you can start with IV fluids, actually. They frequently will have electrolyte abnormalities and fluid abnormality. But if it's a problem where there's delay, and with little babies in particular, you might be thinking about TPN. I heard parenteral nutrition, so providing them with nutrition not through an IV, but through another line. Totally. Loving that. So thinking about how do we nourish these kids and how do we rehydrate them. What post-operative nursing care would we anticipate? We're going to be slowly advancing these babies' feeds. So it's going to be a slow and steady return to feeding. I've actually seen kids advance way quicker than I expected with these kids. But this is probably going to be slow and steady returning to feeding, and the parents and families are going to need your support in this situation and need your support here. So this is one where all of us as a healthcare team need to be working together to support families, to help them learn how to feed their babies, feel okay, and help their kid recover. Is there other stuff here? Yes, sorry, there's one more thing I wanted to mention with this. The interesting exam finding here is that you can actually feel the muscle in the patient's belly. So the exam question that frequently comes up on like board exams and things is about, I don't know about this exam, sorry, I don't know. But the point is this an olive-like mass in the abdomen. So you can actually feel the big muscle in the abdomen, which is very cool, and it feels like a little olive. So that might be your giveaway when you're seeing a kid like this. Okay. Okay, Hirschsprung's disease. So this is an example of Hirschsprung's disease. What happens with Hirschsprung's disease is that the normal neurons that help the gut move at the distal end of the gut aren't working. And what happens is it kind of tightens up and closes. So that then all the stool backs up behind it. Okay? So what I want to show you here is the part that is diseased here is the tiny part. And what happens is, so this is the part that doesn't have the ganglion cells, it doesn't have the neuron cells. What happens is everything kind of backs up behind it. And these kids can present at any point, but they frequently will present in the neonatal period or the newborn period with no bowel movement in a 24-hour period. So you're like, where is this bowel movement? Where is it? Where is it? Where is it? And they eventually, over time, get a distended abdomen. We've also diagnosed this case later on in kids who present with chronic constipation. So they're being treated for constipation, they just don't get better, it's pretty severe, it's not working, and finally someone says, maybe there's something wrong with the gut itself, and they will test and they'll look. And the way that we would potentially treat this in the moment would be an x-ray, we would do an enema, we would give fluids, and if they needed nutrition. And then they would biopsy, and eventually they would repair this by taking out the diseased area, which is that lower part. Disorders of malabsorption. We could talk about this for days. Ones that I bring up as examples are lactose intolerance, celiac disease, which is a gluten intolerance. Sometimes people call it a gluten allergy, but really it is an autoimmune disease where the gut reacts to celiac, the gut reacts to gluten inappropriately, and as a result, the gut becomes very, it doesn't absorb the way that it should, and as a result, people aren't able to grow oftentimes and have other related illnesses as well, other related symptoms as well. Short bowel syndrome is when there's a large amount of the bowel that's either lost or removed for surgery for lots of reasons in infancy. All of these lead to issues with absorption. This is what I was kind of trying to explain with celiac disease here. What happens is in the normal gut, there's all of these villus projections, these villi that come out and allow the gut to absorb nutrition, right? The problem is with celiac, what's happening is the gut starts to react inappropriately to the gluten that's around, and it starts to flatten out, and there's actually villus atrophy, and those normal villi that are projections that stick out of the gut and that allow the gut to absorb everything it needs to start to flatten out. When you remove gluten, you remove the trigger, the villi return to normal, and you can actually have a dramatic improvement. Does that make sense? So there's villus blunting, essentially. And nutrients can't be absorbed, so it is a malabsorptive disorder. There can be impaired fat absorption. You could see diarrhea. You don't have to, though. You could see anemia. You could see weight loss. You could see belly distension. You can see muscle wasting over time. People with celiac will also sometimes have behavioral change if it's not treated. So you could be irritable, fretful, or fussy, or apathetic. And you can have a celiac crisis where you have acute episodes of watery diarrhea relating to the gut not being able to absorb with infection and emotional disturbance. So it can be pretty significant, and it can affect every part of the body, and the treatment is essentially a dietary treatment, which is removing the gluten from the diet. And this is all gluten, not just like occasionally having one. All gluten needs to be removed. So gluten-free diet, treating the associated anemia, and really a big part of nursing care here is assisting with adherence and helping to support families. And really, this is a family affair, you can imagine, for families when they have a kid that's diagnosed with celiac disease. And this is common. You guys probably have friends and people who you know with celiac disease. So I encourage you to talk to them about what that experience is like if they bring it. Okay, we're going to go on to GU disorders. The child with a GU alteration, this is chapter 44 in your text. So again, starting off with differences between the child's GU system and the adult's GU system. The infant kidney is small, though it's proportionally larger than the adult kidney compared to their body, compared to filtration. Kidneys don't reach adult function until about 6 to 12 months of age, and they undergo changes over that time. Infants do not concentrate urine as effectively or efficiently as older children and adults. So it kind of is a little bit different the way that they're functioning. And that's why some medicines, like ibuprofen is a good example, is one that we don't use in infants until they're about 6 months old, and the thought is that it might affect their kidney and it might be processed differently. The assessment. So when there's a concern about GU or renal disorders, so the kidneys or the GU system more generally, the things that we're monitoring closely are intake and output, weight, blood pressure. We're monitoring their urine, and we actually look at the urine. And we look for things like edema, pain, skin color, hydration status, appetites, and in rare cases, seizures. The laboratory tests you may see are urinalysis, creatinine, and you might see this actually in the blood or in the urine. And it's usually high in renal disease. And you might see a blood urea nitrogen, which is a BUN. So we're going to do, for this GU one, I actually use my own daughter, that's Peyton. And the day before this first time I gave this talk, she had these symptoms, so I figured this was a good one to do. So anyway, the point is, now she's 3, but at that time she was an almost 3-year-old, and she knows how to use the potty. And she's been toilet trained for several months. And then I got a call from school the day before this talk that she had 5 accidents in school, which is very unusual for her. Because she was mostly toilet trained by that point. It's also very messy because she didn't have pants at school, so she came home in shorts. Some of those are shorts. So the bottom line is, and she said my butt hurts, which frequently kids don't know. They call it all sorts of things, actually. We'll just go with that. She said her butt hurts. What could be going on? So for in groups here, what could be going on? What are the key questions you would ask the parent who brings them in? And what workup are you anticipating for this kid whose butt hurts and is having lots of accidents? Yes, this actually happened the day before. I was like, this is actually really good. I was like, I need some case for the GU on the I think. I was like, this is perfect. All the time. Or it irritates a lot of I see common reason. Especially nighttime.
Yeah.
And like that.
It just could be more.
Yeah. Could be. Yeah. It's a challenge. Incomplete emptying would be my question. I sometimes will have them double void. So they pee a little bit, hold it, and then say, try again and make sure you get all the pee out. And that sometimes helps too. And then I've had a couple of kids who've really gotten better with just managing the constipation. And the parents are like, that was so simple. I'm like, I know.
Yeah.
simple things work sometimes, you know. All right. It's interesting though, I don't know. All right, what could be going on with Peyton?
UTI.
A UTI, absolutely. What else could be going on with Peyton? What else could be going on with Peyton? Oh, lots of surgery.
Constipation.
Constipation. Okay, and I think you may have heard my conversation here. Yes, totally. Awesome. Or you thought of it, which is great also. So constipation, UTI, they could both be happening because constipation predisposes to UTIs. So both yes and yes. Yes and. Other things that could be going on.
Diabetes.
Diabetes. Okay, so the scary things. That's also what her pediatrician mom was worried about. Like, oh my gosh, she could get diabetes. You do not have diabetes. But yes, totally needs to be under differential when there's new onset urinary incontinence. That glucose leaks into the urine, and then the urine, there's more of it, and you have accidents. Other thoughts? Key questions that you would ask and the workup you would anticipate? What about to get at the diabetes question? What kinds of questions might you ask to pick apart, is this diabetes, is this not? What does diabetes look like when it presents in kids?
The amount of urine?
Yeah, so lots of pee. Lots and lots of pee, absolutely. And how do you get lots and lots of pee?
Excess thirst.
Yes, so you're too thirsty, you're drinking a lot and you're peeing a lot because there's glucose going into the urine, and then the urine is pulled out, and then they're getting dehydrated and they're drinking so much. So excessive thirst and excessive peeing and excessive hunger actually with diabetes too. With UTI, what other questions would you want to ask related to a UTI?
Has there been pain with urination?
Pain with urination, totally. So she says her butt hurts, and we're not really sure what that means, but totally. That could be, it hurts when I pee. And you might ask her, does it hurt, does your butt only hurt when you pee, or does it hurt at other times, and where exactly is your butt? And Mike having her point might also be a good question, which would actually be a telling question. In this case, she pointed to her front, not her butt, but I asked her where it hurts. Okay, other thoughts? I know, right? Okay, other thoughts?
Elevated temps.
Okay, elevated temps. So does she have fevers going on? Fevers would be a sign of an infection causing this, and absolutely a UTI with fevers is a complicated UTI. A UTI without fevers is the bladder and lower. A UTI with fevers is, did it move into the kidneys? Nausea and vomiting would be other systemic signs of illness that would make you think, this is a scary UTI, this is what I need to be on. In fact, we know that young people who have UTIs with a fever, over even a 24 or 40-hour period, can already start having changes to their kidney function. So it's important that if you think there's a UTI and a fever, we need to be thinking about that. And we see bumps in creatinine in kids who have chronic febrile UTIs. Okay, cool. And workup you might anticipate from this discussion? Urinalysis, absolutely. So you're doing either a dipstick or urinalysis or both. Looking for sugar, looking for signs of infection, looking for white blood cells. Other things you might do as a workup? I agree. That's the main thing that's where I would start too. Okay, you got all of this. Constipation, stress. She could also just be distracted. Sometimes kids get distracted and they forget to pee and then they pee. So something really fun was going on. That would also be on the differential. Thinking practically, that's what happens with kids. What are the key questions you would ask? You got all of them, I think. Yes. You could ask about rashes, and we could talk about why that is. I'll mention that briefly. And urinalysis and a culture. So you would send the urine on to the lab to be sent for culture and figure out what kind of bacteria, if there's a bacteria that grows. Okay, so mom miraculously in her home obtains a urine sample, a clean catch urine specimen, and this is not actually what happened in the case, but I mean this case that would be a UTI. But basically the urinalysis shows elevated leukocytes and elevated nitrites. And leukocytes are signs of infection or inflammation. And nitrites are signs of certain types of bacteria, gram-negative bacteria specifically. Thankfully, there was no blood and no glucose and no ketones and no proteins, so otherwise was normal. So you got your urinalysis, and this tells you have a likely urinary tract infection, and you're probably going to start treatment. She did not have fevers, thankfully, but if you were at fevers, you might start treatment immediately. And then you'll send it on and confirm what type it is with culture. All right, cool. Why do kids get UTIs? There's lots of reasons why kids get UTIs, especially girls get UTIs. So there's sex differences, and that means biologics have birth assigned sex differences in the way that the anatomy is the way that the anatomy is. So girls have very short urethras. Little girls who are 3 years old, who are just potty trained, are learning how to wipe. And that can be a challenge. With boys, especially early on, circumcision, whether or not an infant is circumcised, changes their risk regarding UTIs. Uncircumcised boys will actually have a slightly higher risk of UTIs. UTIs in boys in general are rare, so it's still a very small risk altogether. But boys who are uncircumcised in those first 6 months have a little bit higher risk of UTI. Structural abnormalities. So there can also be issues with the way that the GU system is. So the kidneys, the way that the kidneys are connected to the bladder can be an issue, and we'll talk about that too. And there's individual susceptibility. Some people just say, you know, my mom has always had UTIs. When I was an infant, I had UTIs, and then when I was a kid, I had UTIs, and people are just predisposed in some ways genetically too. And during adolescence, UTIs are more frequent in young women who are sexually active, and young people who are sexually active, actually, not just young women. So the manifestations, the way a UTI might present does vary based on gender. It varies based on your anatomy. It varies based on whether or not there's vesicular reflux, which we'll talk about, and the location within the urinary tract. So if it's an upper tract infection, meaning the kidneys start to be involved, they look sicker, they look feverish, they look nausea, they have vomiting. The lower versus the upper tract, so included this picture, basically, if it's the bladder and lower, it's mainly urinary symptoms. So it's mainly painful urination, urinary frequency, they have an urgency to go to the bathroom, they sometimes retain urine. Once you get higher up, that's when the sickness starts to happen, look a little bit sicker, and kids can get really sick. The most recent person I had with pyelo ended up going to the ER. So pyelonephritis is the infection of the kidneys. So important to treat these early. Okay. Vesicular reflux. So there's different grades of the way that urine goes upward. Vesicular reflux refers to an issue with the pathway traveled. Okay? The issue with vesicular reflux is urine goes up from the bladder towards the kidney. You can see here, you can imagine with grade 4 or grade 5 reflux, that urine is going upward in the wrong direction, and that can lead to a higher risk of febrile UTIs. Fevers, vomiting, back pain, think pyelo, and treat quickly. Okay. What treatment would you expect for Peyton's uncomplicated UTI? What symptoms would you tell them to look for? And what teaching would you provide? We'll do about 1 minute here. I want to leave 5 minutes for the Kahoot. So I'm going to try and buzz through this last hour. I'm trying to remember how many more slides I have. Yes, I know. It's okay. We're at 60. Yeah, we're almost there. We're good. All right. For about a minute. What treatments are you expecting if she has a UTI? Antibiotics, so that depends on the type. Your sensitivities varies. I heard antibiotics from the Rochester crowd too. Yes. Okay, cool. And fluids. So lots of fluids and antibiotics. What symptoms are you telling them to look out for? Yeah, systemic ones, and you saw the red one. What were they? Back pain, so you're going to tell the parent or the child. Back pain. Fever. Did I hear nausea? Vomiting. Yes, all those things. Okay, cool. You got it. Perfect. And you might tell them about reinforced wiping and things like that to help with that piece too for a kid this age. There are a number of anomalies that I'm going to go through with pictures here of the GI tract that can occur. Of the GU tract, rather, that can occur. You can have hypospadias, and that's a problem with where the hole is on the penis, essentially. You can see here it's in a little bit of a different spot. It's on the ventral shaft. You can imagine that this might affect the way that urine exits, especially if it's a very narrow hole. That can actually lead to reflux and lead to other issues with the kidneys by backing up urine. Cryptorchidism, this is when a testicle does not descend. That's a problem over time. If the testicles are not descending over time and you notice this on exam or a parent notices it and one is up in the abdomen, that testicle is at risk for germ cell tumors and cancers. So it's actually really important to know whether or not things are descended. And then finally, this is something we see a lot, is fluid collecting around the scrotal sac. It's very common and it's not dangerous, but it can cause some discomfort. And it's common in infants and usually resolves over time. Other anomalies, other disorders of sexual development can occur when there are differences in the way that hormones are present embryologically. This can relate to adrenal hormones that are adrenal sex hormones. It can also relate to other genetic concerns that happen. The bottom line is they can look, there can be a wide range of how the genitals look in these disorders, and they can go from the most common birth-assigned female look to the most common birth-assigned male look. If you look and you're not sure, that can sometimes be a sign that there's some other disorder going on affecting their affecting the way that the hormones were present in utero. Bladder exstrophy, this is a rarer one that sometimes occurs. This is the bladder coming out of the skin. And this is just another kind of developmental and anatomic disorder of the GU tract that needs to be repaired. We are not going to go into this in detail today, but it's important to just be aware that there are lots of different kidney disorders that can happen as well, from birth to ongoing. The two that I wanted to make mention of and that I want you to read a little bit more about in textbook is acute glomerulonephritis, which is an inflammatory disorder that can occur for lots of different reasons, sometimes related to strep, that can affect the kidneys, can lead to gross bloody urine, can lead to high blood pressure, can lead to, and this occurs in like an age 5 to 10 range and occasionally is after strep a few weeks. Nephrotic syndrome is the other kind of common kidney disorder that we see in kids. This is a massive protein loss. In this, because you're losing so much protein, the blood does not have the echotic pressure it needs to keep the blood where it needs to be. There's frequently edema in this too. So you see massive edema, swelling everywhere, and this is more common in younger ages. Occasionally, a child will go into acute renal failure. There's lots of different reasons why this can happen. The way that it might present is with fluid overload because the kidneys are not able to do what they need to do. That can include fluid overload in the lungs and heart failure as well. It can include high blood pressure, and they can have metabolic derangements like metabolic acidosis and hyperkalemia as well. The BUN is oftentimes greater than 120, and that can affect mentation as well. Chronic renal failure is thought to be irreversible, and occasionally we have kids that are on dialysis that you may see if you're working in the hospital setting. Important to think about what the differential for this might be, but not the focus of this talk. Thankfully, is rare. Those are our learning objectives. I want to do the Kahoot, which should take us to 3 minutes early. Okay, we'll be okay. I promised you would get out at least. Okay, we'll do it. We're going to play the Kahoot. Does that sound okay? Yeah. And this will highlight our final, and then we'll be done. Okay, classic. I learned this before. Thank you. Ready to join? Start. Play. What's going on here? Okay, here we are. So let's do the Kahoot, and we'll wrap up with that. And we're still waiting for players. Oh, we got a couple. Great. This is working. It's gonna. Always worry about technology. All right, we're at 28. Rochester crew, are you guys logging in too? Okay, cool. I see you on your phones. Snapchatting. I know what Snapchat is. Okay, cool. Okay, we're at 40. How many people are in the class? 60. Fundus. I like that one. Okay. Topical fundoplication. Okay. Also very topical. Okay. 45, 46, okay. Last call, oh, 50, okay. 51. Okay, I'll give another minute. Last call, up. I couldn't inspire you, no peds for me. Okay, let's go. Ready, 1, 2, 3, we're gonna get started. If you didn't sign up, you can do it with your friends. A 1-year-old is in the hospital for 7 days of watery diarrhea. Name one key element of their care. IV fluids, antidiarrheal medicine, antibiotics, or juice. Okay, perfect, 100%, you guys got it. Okay, IV fluids would be a way to go. Dehydration, severe dehydration in a 1-year-old, 7 days of watery diarrhea, absolutely. All right, cool, I won't explain that one too much. Scoreboard, and Natalie is at 971. A 5-year-old comes in with belly pain and has not stooled in 4 days. The care plan would include an increasing dairy, sitting on the toilet with his feet dangling, that would help him relax, increasing fluid intake, and put him back in diapers for stool leakage. This was my first Kahoot I ever did. I think I would change this. More. 44. Okay. The dangling, so the sitting on the stool, I like this one because it was probably written weird, but the point is, absolutely, increasing his fluid intake would be a part of it, and potentially medications to help him stool. In fact, Miralax would be a really nice option here. But he should sit on the stool with a stool, sit on the toilet with a stool under his feet would actually help him position appropriately. And dairy in the diet. Dairy actually, depending on if you have lactose intolerant or not, which might be different, oftentimes is kind of constipating. So we sometimes will actually cut back on dairy. Okay. All right. 4-year-old is in clinic with fever, vomiting, painful urination, and back pain. Your next step is... Oh, sorry. Abdominal x-ray, start an IV, obtain urine for testing, or an x-ray of the back. $45. Okay, perfect. So 45 people thought obtain urine for testing. I would agree totally. The abdominal x-ray is not a bad thought because you could have some constipation. The thing about abdominal x-rays is they aren't great at telling us whether or not people are constipated. Actually, the person who's reading them and whether or not we think that they're constipated actually influences our read fairly a lot. An IV might occur here, especially in the hospital setting. If they ended up there and if they were really looking sick, they may get an IV for antibiotics, but certainly you'd want to know if they have a UTI. Okay, a 2-year-old comes in with the last question with diffuse swelling, and he has high protein in his urine. And this is one that we didn't talk about as much, so we'll talk about this a little bit more. His care plan includes IV fluids, blood transfusion, a low-protein diet, and steroids. This is one from the reading, sorry guys. Steroids. So this is actually my bad because I buzzed through this slide at the end so we could get to the Kahoot and wrap up. But basically, the bottom line is a 2-year-old who's coming in, what do we think the disorder is here? Do you guys know? Nephrotic syndrome, I'm hearing. Yeah, so nephrotic syndrome leads to massive protein loss. They're swollen all over. The way that we actually manage these kids, so they're losing a lot of protein. So we certainly would not do a low protein diet for that reason because they're losing a lot of protein. We actually want to replenish that protein. We don't do a blood transfusion necessarily, though we do sometimes if we really need to increase their oncotic pressure. IV fluids you might consider doing, but the problem is they're edematous, so it could contribute. So steroids would actually be a good one. And this allows me to highlight here that steroids are actually a treatment that we use for minimal change disease, which is nephrotic syndrome. So that would be one way. And this is not your guys' talk because I didn't get to it. All right, you guys did great. Emma wins. Thank you guys. Thank you guys. Have a great day. We are all good. If there's questions, I'm putting this up here.
Thank you so much.
That was fun. Okay, we're 2 minutes early. I'm still aiming for this 5-minute early.
That's okay.
Okay. Okay.
Yeah, we'll walk upstairs and get you one test.
That'd be great.
For that.
Perfect.
Yeah, we sign off everything. No, this was good. This is, to be honest, this is my least favorite lecture.
Oh, I found this was when I was first going through the slides and I was like, how am I going to tackle this? There was so much. We could do a whole one.
We'll go. I'll see you. You ready to
Interesting, but yeah, and I think a lot of it is kind of you know that's sorry, it's different. That's why I was trying to know idea. A lot of stuff is very different. Where I was like, I'm giving you this, it's seriously not. Yeah.